190-154 and Resolution number 190-164. Mr. Stitt, please read the titles of the bills and resolution.
Bill number 190-152, an ordinance to adopt a capital program for the 6 fiscal years 2020 through 2025 inclusive. Bill number 190-153, an ordinance to adopt a fiscal 2020 capital budget. Bill number 190-154, an ordinance adopting the operating budget for fiscal year 2020. Resolution number 190-164, resolution providing for the approval by the Council of the City of Philadelphia of a revised 5-year financial plan for the City of Philadelphia covering fiscal years 2020 through 2024 and incorporating proposed changes with respect to fiscal year 2019, which is to be submitted by the Mayor to the Pennsylvania Intergovernmental Cooperation Authority, the authority pursuant to the Intergovernmental Cooperation Agreement, authorized by an ordinance of this Council, approved by the Mayor on January 3, 1992. Bill number 1563-A, by and between the city and the authority.
Thank you. Today we continue the public hearing of the Committee of the Whole to consider the bills read by the clerk that constitute proposed operating and capital spending measures for fiscal 2020, a capital program, and a forward-looking capital plan for fiscal 2020 through fiscal 2025. Today we will hear testimony from the following city departments: Office of Homeless Services, Health Department, Behavioral Health. Mr. Stitt, the first person to testify from the administration is?
Liz Hirsch.
Morning.
Morning. Good morning. Morning, President Clark and members of City Council. I'm Liz Hirsch, Director of the City's Office of Homeless Services. Joining me today are David Holloman, Chief of Staff, and Rodney Cherry, Fiscal Officer. And members of our team are also seated back here. Say hi, everybody. Thank you for the opportunity to provide testimony on our proposed fiscal year 2020 operating budget. First, let me thank you for Council's steadfast support for our programs. Despite the highest poverty rate of any major U.S. city, Philadelphia still has the lowest rate of street homelessness. Over the past 3 years, we've slowed the rate of growth of our street homeless population by 86%. Since 2016, the number of people in shelter and temporary housing is down by 13%, but those who are unsheltered has risen. This year, there are 967 people unsheltered, according to the point-in-time count, the source of data used by HUD. Last year, the Office of Homeless Services and our network of more than 60 nonprofit providers helped 16,000 people through our programs, nearly 11,000 through our temporary and emergency housing, nearly 900 through homelessness prevention and diversion, and nearly 6,000 through long-term housing. We estimate that about 5% of those experiencing deep poverty hit the homeless system annually, which we think is extraordinary. That means 95% don't. 15% of those who enter our program are working. Most others have very little or no income. Through our network of providers, we operate nearly 3,500 shelter beds, 255 safe haven beds, 1,200 transitional housing units, and nearly 6,000 permanent or long-term housing units. While we continue to rely on shelter because our primary responsibility is to keep people alive, our goal is to expand permanent or long-term housing. Housed people are not homeless. In the past 3 years, we have added 300 long-term beds, long-term housing opportunities, and 200 temporary beds. Thank you very much for your support that's made this possible. On your tables, we've shared with you 3 documents that provide more detail on both our recent efforts and our plan. You have in front of you our 2018 annual report with highlights of progress made. You have our 5-year strategic plan called the Road Back to Homes, and you have the University of Pennsylvania study of the encampment resolution pilot. These reports provide a lot of information about expanded homelessness prevention, services to families, and the LGBTQ, Latinx, refugee, and immigrant communities. I would like to highlight just 2 aspects of our work before opening it up for questions. Shallow rent. Faced with a significant number of people who live on disability income, that is about $700 to $800 a month, clearly not enough to pay a market rent, we developed a pilot shallow rent program. Its goal was specifically to help people who cycle through our shelters into a stable, affordable housing opportunity using the private rental market and cost less than a full regular rent subsidy, such as through a housing authority housing choice voucher. We started with 40 participants. After 1 year, 39 of them were still housed, so we doubled the program to 80 this year. The model is that basically we use existing rental units. We engage private landlords, inspect the units to make sure they meet housing quality standards, require tenant training, mandatory payment of the tenant portion of the rent through direct withdrawal, and ensure wraparound services. The individuals we serve pay $200 a month, 30% of their income and rent, plus utilities. We pay the rest, but it's a fixed rate below market. We have more landlords who would like to participate. With so much discussion taking place of shallow rent, I wanted to make sure that you are aware that OHS has an infrastructure in place to administer a shallow rent program that is scalable to serve different populations and pay different rent levels. The second focus I'd like to talk about very briefly is the encampment resolution pilot. In partnership with the Department of Behavioral Health and the police, we resolved the 4 encampments in Kensington humanely and effectively. We used a push-pull or carrot-and-stick approach. Each bridge was served with a 30-day deadline notice, after which it would be permanently closed. And through intensive outreach, engagement, and on-site services, we provided low-barrier shelter beds or treatment slots to everyone we knew to be homeless in the camps. After 9 months, 65% from the first 2 camps were still service engaged, and nearly half were still in treatment and/or housing. Independent researchers from Penn hailed this approach as a success, saying that providing services alongside the closure defined the pilot's success. This approach has drawn national attention for its effectiveness in the face of tremendous challenges that very much still plague the neighborhood. We continue to address the homelessness in Kensington as well as throughout the city, but in Kensington through the Resilience Project, which brings together more than 30 city departments, offices, and agencies to work in a coordinated fashion to improve the quality of life for all residents. The requested additions in the OHS budget this year are largely to address this opioid-driven homelessness. We thank you again for your support and your investment in our work. Thank you for this opportunity to testify, and I'm available to answer your questions.
Thank you. Thank you for your testimony. I've just got a couple of questions. Again, I'll do this every budget hearing. Shameless plug, narrowing the gap. I don't know if you've seen this document.
We have indeed.
The council.
Read it cover to cover.
Yeah, so anyway, we talk about, narrowing the gap, preventing poverty, reducing poverty in a meaningful way, laying out a series of strategies associated with what we can do locally. Clearly, your work involves categories of individuals and families that fall within the at or below the poverty level. Can you tell me what your department is doing, and if you can align it with some of the things that we're proposing in this document, or just generally where we're going with that, because we genuinely want to have a measurable reduction in poverty, not just a feel-good reduction, because feel-good reduction is when we have announcements and we're having programs, which we've been doing over a series of years, but every year we're still at 26%. And lo and behold, I've actually in our research found out that we've been at the #1 or #2 slot literally since the 70s. So this is clearly a generational issue. So can you talk to me in some specific terms on how we get people moved towards that needle of getting them above that category?
Yeah, we invest a lot of time and energy in thinking about this. It is clear to us that having a place to live doesn't cure poverty, but it is impossible to lift yourself or your family out of poverty without being housed.
Right.
And so the first order of business, and I think where our strategy and yours align, is housing, housing, housing. Everybody having a safe, secure place to live, whether that's through preservation, the production of new units, whether it's innovative programs like shallow rent, or whether it's expanded rental assistance for the very, very poorest people, those below 30% of AMI, so that they have that opportunity. We call this a housing first philosophy, that once you have a place to live, that is the platform that we all need to be able to hold a job, sustain our recovery, sustain our physical health, raise our children, do well in school. Housing first, so that's where we fit together.
No, I concur that it's very difficult to achieve anything without a base of operation, be it a home, be it a place where you function and work and whatever, but having an affordable place to live is clearly something that we can do locally.
I think about, where do you put your glass of water at night if you don't have a bedside table? Where do you keep your pills, all
Right.
of those things, your clean set of clothes. So,
Right,
yeah, the
okay.
basics.
All right, so we look forward to working with you on that.
Thank you. We look forward to working with you too.
So I'm as most people are, a lot of elected officials, a member of the National League of Cities, and we talk to various colleagues around the country, and I'm a part of this. I think we formed it about 3-4 years ago, Conference of Council Presidents, and we talked about homelessness. And the interesting thing is that across the country, this is an issue. And so, but the one thing you get to share conversations and strategies with people from around the country. And one of the things that we were asking other council presidents about was this issue around homelessness and affordable housing. And apparently in Albuquerque, New Mexico, along with a number of other cities, they started this program, the VAN program, where they literally pick up panhandlers and offer them money for a day's work, and oftentimes they ask to clean up litter around the city. As you may know, I represent Center City, and as a result of that, it is to some degree ground zero for a lot of this type of activity. So I'm always getting store owners and property owners calling me, Darryl, what are you going to do? I got this guy in front of my place. He won't move. Technically, we can't make him move. But he's like, harassing my customers, asking them for money. They don't want to come in. You get the gist. So what do you think about a model where we, I guess to some degree, a public works initiative where we get people and we ask them to do certain public works in exchange or in lieu of them basically standing on a corner or standing at, I guess it's Fifth Street, coming off the bridge.
Yeah, right.
And going on the bridge. It's kind of dangerous, and you're actually on the bridge, literally out there asking for money. What do you think about alternative opportunities for people like that?
Yeah, there's a better way, Albuquerque. Yeah, we would love to be able to do that. And there's two things that are actually happening right now. The first is that the Barra Foundation funded Mural Arts program together with Mental Health Partnership to do a same-day pay program. And they're going to begin, they may have even begun yesterday, to take folks directly off the street who want to work, and they're going to be painting murals in the concourse. And I don't remember how much they'll get paid a day, and Scattered Good is evaluating it. And then they'll get wraparound services through the Mental Health Partnership. So that pilot is live. And then the second pilot that Harold Epps from Commerce and we are working on together is more along the lines of what There's a Better Way Albuquerque does. And we're looking at the work actually being run through CLIP, because they already have an infrastructure supervisors, vans, work to do. And so we're trying to figure out how to organize that. But our hope is that in the next fiscal year, our plan is that in the next fiscal year, we would also launch a small pilot to try and get at the economics of panhandling, because we did a panhandling survey, as you recall, and what we found is that people do it to make money. And they actually show up in general at the same place at the same time every day, which is work behavior, but they don't have, there's too many barriers for them to hold a regular job.
Right.
So we're hoping to do that together with, for example, First Step staffing. What First Step says is that a substantial percentage of the people who walk through their door aren't ready for the first step. They need an on-ramp. So we're really looking at trying to pilot that on-ramp. So we're very enthusiastic and pursuing it.
Okay, so by an on-ramp, because there is a simple reality that a lot of people, if you create an environment where they can do some sort of public works and get paid, that they're probably going to go out and buy some product that may not be legal, illegal, or helpful to them from a health and safety perspective. So how do you deal with that? I mean, how do we deal with the realities of, I got cash in my hand, I'm going to buy some K2, I'm going to get some weed, I'm going to get some chronic, I'm going to do whatever, right? I mean, that's just a reality, right?
Yep, that is a reality.
How do we deal with that?
So the model has wraparound services, and the idea is that as people, and I think what they found in Albuquerque and other cities is that as people have opportunities for legitimate ways of earning money and they have the experience of contributing and dignity of work, that then that becomes a link for them with the services that are available, so that the program is actually nested with a set of services. But we do expect that some of that will continue. I think what it means then is they're not stealing or panhandling to get that money. And just by the by, the number one substance of use among homeless people, especially in Center City, is alcohol.
Yeah,
So,
well, that's a given.
yeah,
That's actually legal, so
there you go.
that's no different than everybody else, right? You know, you come down here on Friday nights, there's a whole lot of alcohol going on.
Yeah.
So,
Yeah.
Hub of Hope. I want to thank you, obviously, for your participation early on in that project. We were quite excited. We cut the ribbon. We all had very, very high hopes for that particular location. It has hit some bumps and bruises. Actually was down there a couple of days ago. It was kind of clean. I don't know what happened. Somebody, a newspaper story or something. So
Yep, we're working.
what's our long-range game plan for that? Because
I'm gonna let Dave.
yeah, we gotta figure, because it was it's a good idea, and I understand in the actual Hub of Hope, you know, it's working. You know, we're getting people engaged. You know, the long-term viability of those individuals in terms of them moving them out of their situation. I guess the jury's still out on that, but at least while they're in there. But the issue surrounding and leading to the Hub of Hope is challenging, and I frankly don't like going down there because the store owners, not the individuals, the store owners are beating me over the head. And Councilman Greenlee and myself, you know,
Three store owners.
yeah, they're all over me. You know, it's like, well, what are we gonna do, right? What are we gonna do down there? And I know it's not just simply on you guys, it's SEPTA and the city and everybody else.
Good morning, Honorable Clark and all members of council here. As you said, we have done a lot of work. We continue to hear the complaints that comes in, not only from the store owners, but also from participants who utilize the Hub of Hope. And so we think that the Hub of Hope is the right approach. I think 2 years ago when we heard a number of complaints about people having unoccupied time in the area Center City, such as Panhandle, this was a great concept and idea. So what we have continued to do has been partner with the business owners down there, also with law enforcement, and also stepped up our social service efforts. Part of the reason why you have seen a significant change in that area, we have started this over a year ago. We have hosted a number of different training to really educate the general public, members of the District 47, risk management, about what is being done in the Hub of Hope. What we have found was that a significant number of people who are around the Hub of Hope aren't homeless. And so what we're trying to do is make a clear distinction between individuals who are actually utilizing the Hub of Hope for services versus people who are coming down there doing predatory behaviors. So as an ongoing and long-term strategy, SEPTA and the local Philly PD has been phenomenal in partnering with outreach. We recently hired an outreach/behavioral health specialist to really identify individuals who may be homeless and struggling with some behavioral health to get them a correct intervention, which is social services. The other thing Project Home has done with us, we're continuing to meet on a bi-weekly basis, really talking about creating a by-name list of folks who are really, truly struggling with homelessness, housing crisis down there. I think all hands are on deck in terms of a project. I think, Liz, when you indicated about the day labor program, we're looking at a multitude of issues. We know it's not going to be a one-for-one strategy, but we're trying to quickly wrap areas. We are taking part of the encampment resolution pilot, taking best practices from there and putting it in that particular area also. What we have found is that I always like to say bless people with services. The more service that you're able to provide to people, the more opportunities that they get. And we also know that rounding the SEPTA concourse is seasonal. You know, during the winter months, majority of people who do not like being out in the elements are hanging in the subways. And so what you're starting to see is a shift in behavior. But we are trying to work as closely as possible with different agencies that are coming in contact with them to keep wrapping services around them.
Okay. All right, thank you. Chair recognizes Councilman Greenlee.
Thank you, Mr. President. Just quickly on the Hub of Hope, I'm glad you noted, sir, that a lot of the problems seem to be, and I'm hearing this from talking to SEPTA and the business people, are the folks that are not actually homeless, but they're there to take advantage, selling some illegal products or whatever, and that seems to be a big thing. And I know that's more of a police issue, but I think that is it seems to be a big part of the problem down there.
Yeah, absolutely. And I think there's an opportunity also to engage in those individuals. Right. I think when we talk about the poverty rate, unoccupied times only lead to a number of different behaviors. And so with these day labor programs, we're hoping to develop programs that engage those people too that are engaging in preparatory behaviors.
That would be good. Although they might think they're occupying their time right now by doing what they're doing. But I want to go on another note here. Liz and everyone, I know you have a difficult job and only so much money to deal with. But as you know, I brought up both privately with you folks and on budget hearings about the Women Against Abuse shelters, the two of them. And I see in the budget detail, page 26, is $700,000 decrease in emergency shelter. Now that's kind of lumped together, but Women Against Abuse shelters are one of those that are in the group. And I'm wondering, are they receiving a decline in their funding? Or because I know we try to every year bring a little bit more in there. So do you know, are they getting any decrease?
We haven't done a detailed spending plan at this point in time.
I know before, and I think we had a meeting, I think budget director was in there, that there would be discussion with those of us, I'm one of them, I'm not the only one, that has concerns about those two shelters and making sure that they're as properly funded as we can. Is the plan to still do that? Is to still have?
Absolutely.
Okay.
We try to keep our word.
Okay. All right. Because so you're saying you don't know at this point how that money's going to be changed? We
haven't done our spending plan yet.
Okay. So when the budget's passed, it gets to that point, will we know then? Or will you have a detail then? Or?
Yeah, the process is that, first of all, we have to do the letters of intent, get the scopes out, and the proposed budgets for all of our providers, and then begin to make those decisions.
All right, well, I guess I just want to go on record saying that and I think a lot of us in here would be not supportive of seeing those, and I know, look, the homelessness issue, the shelter issue is important to all of us generally, but I've always made the argument that those two shelters may be the most urgent, because you're talking about if the women and their kids don't get out of that situation, that woman could be dead tomorrow. So I think there's nothing more pressing, in my opinion, than those two shelters. You know, again, not taking away from anything else that you have to do and any of the other shelter system and all. It's all important. We're trying to get people off the streets. I get it. But those shelters to us, you know, to a lot of us, is a tremendous priority. So I hope there can be some discussion before that final decision is made with all of us that are interested in this, to see that those two shelters are maintained as much as possible. So I would make that request now. Okay.
I think we are very much in agreement that matters of life and death come first.
Okay. All right. Okay. I appreciate that. Thank you. Thank you, Mr. President.
Thank you, Councilman. Chair recognizes Councilman Dom.
Thank you, Council President. Good morning. Do you have any statistics on the homeless population that we need to desperately help versus those people on the street who are not homeless but are trying to earn a living?
We take responsibility for those people who are homeless and that we know are homeless. And so when outreach goes out, they engage everybody, or if the police get a complaint or know somebody who is of concern, they also go to outreach, and outreach maintains data on all of those individuals. But we don't maintain a census of people who aren't homeless or are, because we can't really tell by looking.
Right.
And you get into very gray area when you start making assumptions about people. So I would say that the answer is no. We know a lot about the people who are out there who are homeless.
Okay. And what is our average cost now per bed? We
For,
look for new beds that you're looking for. What is the cost?
Sorry.
now?
Yep.
What is your cost per bed?
So for an emergency shelter bed, it's between $40 and $45 a day per person. For our, and that's an ongoing cost, and the average stay, I think we're between 5 and 6 months, although it's going down. For permanent housing, I believe that it ends up to be about $12,500 per year, and for rapid rehousing, which is a one-year subsidy, it's about $10,500.
Okay. So I have some questions on your budget. I just wanted to clarify. It says on page 12 of your budget detail, it shows fiscal year 19 appropriations for a U.S. facilities contract of $747,000.
Yes.
Then the fiscal year 20 proposed does not include any money for U.S. facilities. Is that being negotiated, or did something happen there?
We're in the process of, I believe we're going to issue an RFP for the maintenance service for this coming fiscal year. And once we get the detail on that, we'll have more information.
Okay, so it's being negotiated now?
Yes, it will be.
Okay. And your testimony mentioned that you intend to develop a facilities strategic plan this year. How will that strategic plan help you understand the department's assets?
Well, the department, I'm not sure what you mean by assets.
All your assets of the department, the beds you control, all your facilities.
Well, the facilities that are owned by the city are operated by the Department of Public Property. We're basically a user of those sites. What we have discovered, Councilman, is that we have a lot of different structures. Some are owner-operated, some are leased by the operator, some are leased by the city. It's really a mishmash, and that makes it very complicated to administer, and it makes it complicated to maintain them. So what we're trying to do is to understand the structure of all of our facilities arrangements so that it can be streamlined. We're looking for some efficiencies, we're looking for cost savings, and we're looking for higher quality property maintenance. So we're looking at all of those elements of running those 30 or 40 facilities in a way that's more efficient, effective, higher quality for the people, and hopefully we'll be able to recognize some savings, but I don't know yet.
Okay. And then public properties budget detail for rental payments shows two line items for OHS, an $80,000 rent payment towards 804 North Broad and a $685,000 rent payment towards 801 West Girard. Are these facilities that OHS plans on using long-term? Do we know, or is it just a short-term?
At this point in time, I believe they're one-year leases. The 804 North Broad is our single men's intake site. It's moving from next door 802 North Broad. So certainly our hope would not to be moving again, because moving is expensive, but it's, we think it's going to be a better situation. 801 West Girard is our IFE Wellness Center. Again, it's a one-year lease that we're assessing if it's effective and if it works well, and the community is happy with us being there, then we'll think about what's next.
Is there any publicly owned property that we could utilize through the city?
I don't know. When individual properties, for example, in this last year, we've lost 2 sites. They were church-operated, and they were being demolished for development in West Philadelphia. And at that point in time, public property identified additional sites that might be available that the city owns. 2 considerations. One is whether it's most advantageous for the city to own and operate the site. And I think there's pros and cons, and that's part of what we want to get to with the plan. And then the other issue is availability, whether it's zoned properly, whether it's suitable. So it ends up being a fairly complex decision financially, programmatically, where we site any of these facilities.
Let me ask you another question. You know, we've talked about tiny homes before.
Yes.
And I think it only works not as infill, but as like 20, 30, or 40 clustered together. And I think the cost of these tiny homes are $80,000. So just when you think out of the box, if you're telling us the costs are $12,500 to $15,000 annually, and the tiny homes are $80,000, and if we were to float a bond or have a debt instrument, whatever, that is a 10-year term, in other words, fully amortizes over 10 years, our interest costs annually would be like $3,300, and amortizing it would bring the total payment to about $800 a month. We'd actually be paying a lot less than we're paying for the $12,500 and $15,000, and after 10 years, we would own these facilities. Is that something that we should be looking at?
We would love to work with you on any alternative that's more cost-effective and gives people more dignity.
Right, I mean, because then you could have a whole community, and you could have nice homes and nice properties, and these are nice homes, these tiny homes, they're very nice, and the costs are probably half what we're paying now.
In Seattle, what they did was they actually passed an ordinance that enabled the establishment of tiny homes. I believe that the International Building Code allows for smaller homes now, but there are some hoops that would need to be gotten through in order to be able to, to physically construct a tiny home. As I understand, it's not my area of expertise, but we would welcome the opportunity to work with anyone who's interested on the alternatives.
I think we're doing a pilot in Councilman Squilla's district of a tiny home. So maybe when that's up and running, we should take a look at it and see if it's duplicatable.
Sure.
Okay, thank you very much. Thank you for everything you're doing.
Thank you.
Thank you, Council President.
Thank you, Councilman. Nobody else is teed up to ask you questions. One last question. In your budget detail, you highlight the rapid rehousing efforts, and you said the efforts have an 85% success rate. Real quickly, can you talk to me about how and why that's successful?
Well, I don't know how you did in school, but a B is a pretty good grade for me. The rapid rehousing is, the idea is that people move out of shelter quickly. And we've really focused on families to get, instead of growing roots in the shelter, the idea is to get them into a house in a neighborhood where the kids can go to school and they can build a support network there. So it provides short-term, it provides some financial assistance like debt relief. A lot of times people have utility bills, et cetera, maybe an eviction judgment against them. And then it provides for a year, sometimes a little bit more, worth of rental assistance and case management services. And the goal is during that year, while they have the subsidized rent, to be able to find a roommate, move to a place they can afford, get a job, do other things that can help them be able to sustain a home in the community. And the 85% is that is people who do not return to the shelter system.
Okay.
And I think that's a 2-year look back in that particular case.
Okay, thank you. Chair recognizes Councilman Jones.
Thank you, Mr. President.
Welcome, sir.
Good morning still. A couple of quick questions. What is the total number of people that were, and it's in here probably, but help me out, that have gone through the shelter system last year? Fiscal
It's about 11,000 between emergency and transitional housing.
Of that 11,000, how many of them were considered working poor?
15% of the people who have entered our system were working. The average income for people in our system is really $10,000 or below. We're talking about people who are living in deep poverty, many of whom have zero income, some of whom have SSI or SSDI, and then some of whom may be on TANF. But these are extremely poor people.
Have you had an opportunity to look at, Cleveland's example of lease to own? And are you familiar with that at all?
I am familiar with lease to own.
Is that something that you could use as a rung to help people get into homes, rent the homes, and then eventually purchase the homes? Have you looked at the viability of that application to our Philadelphia situation?
We have not. I know that the Housing Authority has run a very successful program that enables people to move from renting to owning. We really are more focused at this point on just getting people into some kind of rental situation or some kind of shared living situation where they can stabilize.
Do you still separate male, female, and then families?
In general, we adopted this year an equal access policy that loosens that. We have some men on our staff who have become quite activist about the inclusion of fathers, and they've really helped us all look in the mirror and try and do more to keep fathers and mothers together with their children. So we are trying to do that through our equal access policy.
So could you define or give me a quick breakdown of the 11,000? How many fall in which category?
About half are families and maybe a little less, maybe 45%, and then the rest are singles. Most homelessness still is men, but we've seen a growing number of women experiencing homelessness. We've also seen a graying of the homeless population, and we've seen a big uptick in the number of people who have physical disabilities and/or mobility problems. And in fact, one of the issues that we're really grappling with now is hospital dumping, where people are discharged from the hospital to the front door of our shelter, and we've had to train our security guards to watch for ambulances so that they don't bring people to shelter who really need more care than we are able or really legally allowed to provide.
Has there been any dialogue with the hospitals about this practice?
There is, and there's a policy and a procedure in place, and so we've been working with them to try and follow that procedure, but I think they're struggling with the same issue we are, which is places for people to live who are very, very poor and who also have some kind of disability.
When you deal with that 11,000, do you look at the causes of the homelessness and why they became
Yes.
homeless? And
Yeah.
can you break that down?
I don't have that breakdown in front of me, but when people come to one of our two intake sites, they sit down with a social worker for as long as it takes to help understand what's going on. Our first effort is to try and help them see if there's a safe alternative that they can go back to. And so we've done training with our staff this year, and this is under Bruce Johnson, who's sitting here. We've done training with our staff this year with national experts on mediation, because sometimes there's a family conflict that leads people to get kicked out, and if we can, we try to help them go back to somewhere, or through other prevention and diversion efforts, maybe move into a different place, or throw a little money in the pot. And so we've tripled our homelessness prevention and diversion over the last couple of years, thanks to the local housing trust fund, because we would really rather people not end up in shelter. But the reasons that people become homeless, the number one reason is money. They don't have enough money to pay the rent. And then we see with families, that the most at risk are young women with young children who themselves have been in the child welfare system or the homeless system. So those are kind of some of the trends that we see, but we could provide more detail if you would like.
How do you interface with rental assistance for emergencies when people are faced with that homelessness? Has that fund been adequate to address some of the problems?
No, we think that based on the data that we have, which is somewhat limited, we think that we're providing assistance, homelessness assistance prevention for about 20% of those, between 20 and 25% of those who come to our front door saying that they are facing imminent homelessness. And that's separate from the prevention and the Philadelphia Eviction Prevention Program.
What was the allocation last year towards those rental assistance programs?
I think it was about $2.2 million, and a chunk of that came from the local housing trust fund. That was about $750,000, and then we redirected what's called emergency shelter grant dollars also for some of that. I think there's some home money that comes through DHCD, and there's CSBG dollars, which is federal money that comes through CEO. And we combine all of those. And then there was a new revenue source that came from PHFA and the Federal Home Loan Bank called Home for Good, and that also added to the number of homelessness prevention grants that we were able to provide for people.
So we have $2 million worth general pool of rental assistance, and if I heard you correctly, we need another 80%, which would make it 10 million.
That'd be nice. That would help.
But is it accurate?
To the best of our knowledge, based on the data that we have.
Final question I would have, based on your records last year, were there instances of assault in the homeless shelters?
Assault?
Yes.
No, not that I know of. Our shelters are remarkably safe. They're certainly much safer than people sleeping on the street. And we do require an incident report. There were some overdoses, and sometimes there's, verbal altercations between people, usually not physical. We have set up a participant call line. So we have two fail-safes. We have a participant call line. So any individual who feels that they're unsafe or being treated poorly or there's conditions that they want us to know about can call that line. It's 686-4700, and they can leave a message 24 hours, or they can talk to a social worker between 9 and 5, Monday through Friday. And then we have what are called incident reports. So if anything happens, they surface it up. And then we have an appeal process. So if people feel that they're being treated unfairly or something bad has happened that they want, to get fixed, they can grieve and appeal through our process.
Final question, Mr. Chairman. What is the average stay from the time a person comes to a place like Elijah Shirley until they get some type of long-term housing assistance? What is the average time?
I think it's 175 days on average. But I will tell you that only about a quarter of the people who come to our shelters exit to permanent subsidized housing. It's just not available. The PHA, as you know, doesn't have housing choice vouchers or public housing subsidies widely available at this point in time. So many people end up exiting to live with friends or family or some kind of informal situation. For those who do exit to permanent housing that's affordable to them, 93% do not return to homelessness, which gets back to our point, which is that housed people are not homeless. And if we're to see any expansion in what we do, our ideal would be that it be in housing that's affordable to people at 30% of area median income or below, and especially those folks earning about $20,000 and below. And when they have that and the services they need, they don't return to homelessness by and large.
I look forward to working with your department to come up with long-term solutions for lease to own through cooperation with PHA and other stakeholders so that we don't keep putting people on that hamster wheel and winding up. And it's good news that they don't wind up back homeless, but we can improve that number, and I look forward to working with you on
Thank
that.
you.
Thank you, Mr. Chairman.
Thank you, Councilman. Chair recognizes Councilman Dodd.
Thank you, Mr. Chairman. I do have three other questions I wanted to ask. My office received the Health and Well-Being Report for 2019, and one of the highlights was providing temporary jobs to 670 individuals who were formerly homeless or at risk of experiencing homelessness. I wanted to find out what we're doing to find these individuals permanent employment.
Most of the people from our system who gain employment, I think, are working through First Step staffing. And as you know, it begins with temporary employment, and then the effort is made to try and help them get into a permanent position. So while we don't actually run employment programs, we really stay focused on homelessness, we are supporting their efforts and working with them to give people the best opportunity possible. And we have, in our new strategic plan that just launched in January, increasing employment opportunities for people experiencing homelessness is one of our 5 top priorities.
And do we need more resources for employment and job opportunities?
I think especially First Step staffing, it's very, very effective, and I think they are under-resourced for the demands on their system. But the other thing they need are employers to list their jobs through them, especially employers in Philadelphia.
Okay. Second question I have is, you mentioned with Councilman Jones's question that of the 11,000 people that go through the system, 15% of them are working, I believe?
That's our number, yes.
Okay. And of the 15% that are working, do any of them have children?
I would assume so, yes.
And have we helped them with like the earned income tax credit and other benefits?
You bet. We have the program come every year and speak to all of our providers. We distribute the materials widely, both in print form and through email, and we've been doing that for 3 years. And in the time I've been here, I can't speak to the time before that. Absolutely, we want to do everything we can to make sure that they get every available dollar, and thank you for providing that connection for us.
And do we also, because we can have like Campaign for Working Families and United Way show up at a location and do their tax returns for free to help them get the refunds?
I believe that all that information has been given to our providers, but we will continue to get the word out because it's such a great resource for them.
Okay. I mean, the money available through the earned income tax credit is pretty, just not to beat a dead horse, but single parent, $44,000 of income, 2 kids under 17. If they're making $20,000 or $25,000, they can get checks up to $5,700 per year and file back 3 more years. So that's a game changer. That's like $23,000. It's a lot of money.
And one of our providers in particular, the Interfaith Hospitality Network, has really had that as a key strategy in helping people get into an apartment to really work around that investment. But they have a higher number of people, families who are working.
Okay, great. I just wanted to mention on Sunday, this past Sunday, Easter Sunday, I drove through Kensington. I went to all 4 locations, and I saw that it was, in much better shape than it was before. But there was a street on just off of Emerald Street. I think it's called Sterner Street, where there seems to be 25 or 30 people now that are congregating on that street. So I'm just giving you, you probably know about it, but it seems like we need to address that issue also up there.
Yeah, we are very much aware of the people. The police do a weekly count, so and Outreach works very closely with police, and we're actively out there. Just because we're not doing encampment resolution doesn't mean that Outreach isn't out there all the time. And the police are out there engaging people, offering services, offering beds, offering options for treatment. All of our beds are full at this point in time, but we're continuing to work with people to try and help them move forward, to create that flow through the system and more space.
What do you do in the situation where somebody refuses help or treatment?
We keep trying.
Has that been a problem?
Well, our experience is that when we first did the encampment resolution a year ago, We thought that it'd be really hard to get people to identify themselves and accept help. And within like 5 days, 189 people had not only filled out a survey saying what they wanted or needed, but they had given us their name, social security number, and birth date, which meant that we had all of their identifying information. So when we are able to offer people what they really need and want, we have a very good success rate at getting them in. I think the obstacle is first of all, the addiction itself is so profound and it changes the functioning of the brain so that everything else stops mattering less than getting more of the drug, and they feel very physically sick within a short time when the effects wear off. And so one of the things that actually Prevention Point has been doing is the induction into buprenorphine on the street, which helps people feel better and it helps them think more clearly so that they can then maybe start to think about, could I come inside or is there something different for me? So I'm sure that DBH can talk in their testimony more about how you engage people in treatment, but that's what we've been trying to do, is we're trying to do everything we can get closer to treatment on demand so people don't have to wait, provide transportation, engage them in whatever it is that they are willing to accept. Might be ID, might be a place to sleep, a safe place to put their stuff. It might be a shower, laundry, might be wound care. Anything that they will accept, we try to use that to bring them in. And one of the things we learned from the encampment resolution is that over time, once we got people service engaged, that over time we were able to engage them in more and more services. So that's really the strategy that we're employing.
Of the people that were in the encampments, what was the total count of the 4 encampments?
I think on our by name list it was 313 for the 4 camps.
How many of the 313 were we able to help and bring in for treatment?
I don't have the data right now on the last 2 encampments, but on the first 2, after 9 months, 45, close to 50% were still engaged in treatment and or housing, which we think is an extraordinary success rate.
Okay, all right. Thank you very much. Thank you for your department, and thank you for everything you're doing to help us.
Thank you. And
thank you, Mr. Chairman.
And the team.
Thank you.
Well, thank you, Councilman, and thank you all for your testimony and your ongoing continued support in addressing these issues on an ongoing basis. So thank you so much. That will be all for today, unless anyone else has any other questions. That being none, thank you. The chair now asks that Department of Health, Dr. Farley, Commissioner, if you would please approach with your executive team and state your name for the record, and when you're ready, you may proceed with your testimony.
Is my mic on? Yes. All right, ready? All right. Good morning, Council President Clark, and then Chair of the Committee and members of the City Council. I'm Dr. Tom Farley, Health Commissioner. Joining me are Jane Baker, my Chief of Staff, and Sammy Girard, Chief Operating Officer, and the other directors of our divisions are in the audience here today. You have my written testimony. I want to highlight just a few areas. The Department of Public Health continues to provide high-quality primary medical care at 8 health centers to people regardless of their ability to pay for care. Last year, we served over 77,000 patients in over 336,000 patient visits, about 40% of which were for uninsured Philadelphians. In alignment with the Narrowing the Gap report, we are expanding benefits enrollment efforts in our clinics. Our goal is to ensure that patients we serve have access to all the benefits to which they are entitled. In the past year, Health Center 10 was recognized by the federal government as a patient-centered medical home, and we're now applying for the others to get that same recognition. Health Center 10 in the Northeast is also the health center that sees the greatest number of patients. To handle this demand, we are remodeling the building to add extra exam rooms. We're also planning to open a new City Health Center in the lower Northeast Philadelphia, the part of the city with the poorest access to primary care. The other divisions of the department perform a variety of activities to prevent disease and promote health. Those activities include promoting vaccination of children and adults, preventing the spread of HIV, investigating outbreaks of disease, inspecting restaurants, preventing lead poisoning, combating air pollution, helping women have healthy pregnancies, promoting the health of young children, and preventing heart disease and cancer by promoting healthy eating, physical activity, and smoking cessation. We're also working with other agencies to combat the opioid crisis. The Department of Public Health is focusing on reducing inappropriate prescribing of opioids, expanding medication-assisted treatment for substance use disorder in primary care, and preventing fatal overdoses. This past year, the Department of Public Health worked with many other agencies to develop the Roadmap to Safer Communities plan to reduce gun violence in Philadelphia. We're excited to be part of the implementation team for this initiative and to take on a few specific activities called for in the plan. The need for the initiative was highlighted in a new special report that we just published on the health of African American men and boys. If you haven't seen it, here, it's a great report, in Philadelphia. We also recently published our second annual Health of the City report, which summarizes Philadelphia's most important health problems and the factors that contribute to them. I'm proud that the Health Department has a diverse staff. Among 901 staff members in full-time positions as of November 2018, 77% are minority race or ethnicity, an increase from last year. People who are bi or multilingual make up 15% of all full-time staff, with Spanish the predominant second language. Our staff members speak a total of 48 languages. I'm happy to answer any questions.
Thank you, Doctor, for your testimony. Chair recognizes Councilman Greenlee.
Thank you, Mr. Chairman. Good morning, everyone.
Good morning.
Commissioner, first, let me just say thank you. I know we've worked together on a few things, some more successful than others, but it's been great working with you. You certainly have been dedicated to the health of the city of Philadelphia. We appreciate that. You mentioned the health center and the new one you're establishing. I assume the idea is to take a lot of the pressure away from Health Center 10. Is that basically
Yes,
the main
Health Center
idea?
10, we have maxed out on the services that we can provide given the existing
Right.
facility. And so we're expanding the exam rooms, but we feel even that is not going to meet the demand. So we think just more services are needed in that neighborhood of the city.
Right. I mean, it's something I brought up over the years, so it's my last chance to do it. But I'm glad that, again, it doesn't totally solve the problem, but it seems like it would lessen it some because I was up there one time and it was just like brimming with people and services.
Brimming with people almost every day.
Yeah,
And
right.
I should say, in addition to our trying to build an additional clinic to provide more services ourselves, we have been encouraging other federally qualified health centers and health systems to locate services in the neighborhood because the need is so great there.
And on the health center, is there one or two particular concerns or health issues that come out of those health centers? Particular health issues, I guess is.
So, the health centers provide a very wide range of services, more wide than many people might recognize. It's clearly begs to primary care, but also mammography, for example, dental care. So there's an awful lot of different things we do there. If you're looking at what are the most common conditions we treat there, for adults it's diabetes and hypertension, those chronic diseases which lead to heart disease and cancer, which are the biggest killers. So we're trying to prevent those with our efforts to, for example, reduce smoking. But at the same time, we are dealing with those conditions in individual patient care to try to reduce those the complications from happening.
Okay. All right. Thank you. Again, thanks for all you do.
Thank you.
Mr. Chairman.
Thank you, Councilman. Chair recognizes Councilwoman Bass.
Thank you, Mr. Chairman. Good morning.
Good morning.
How are you?
Good morning.
So I want to thank you. I'm the chair of the Health and Human Services Committee, and we've done an extensive amount of work together. And I just really wanted to take this as an opportunity to thank you, Commissioner, and thank the entire Health Department for all of the hard work that you do. And we've had some great successes, I believe, in terms of the work that we've done. And even when we haven't had a success legislatively, we have had success in terms of awareness. We've raised the bar and we've, increased the conversation about what should be done and how the city should be helping those, particularly those who are most in need of health care in our city. So I just really want to thank you and your entire team for all of the work that's done by the city's health department. I have a little bit bit of a heavy heart this morning. I'm late today because I just stopped by the house of Mike Abdullah, who was a frequent, what we call a frequent flyer here in City Council. He was an advocate and a protester, and someone that we all knew pretty well. And he passed away this morning of a heart attack. And, you know, just last night he was out doing his thing, advocating, fighting for communities, and, you know, woke up this morning and just gone. And so, you know, I'm just thinking about that, and I have a whole line of questioning here, and it wasn't really necessarily related to that, but we talk about health disparities all the time, and we talk about what is it that we can do to address the health disparities that exist in Philadelphia, and it's just numbing to me that we have, you know, we call ourselves this great city of eds and meds, and yet we have such a disparity, such a disconnect between what's happening in our medical communities and what's happening in the hood. And how do we bring those things together? How do we bridge that gap? And I know we talk about it a lot, but there really just doesn't seem to be any sort of a roadmap that will get in front of something that is preventable. I'm no physician, but I believe someone like Mike Abdullah and probably what he experienced today was likely preventable with medical attention. And a lot of the times, you know, when you see, you know, I'm sure through your office, the coroner's office and so forth, you see so many things that are preventable and that would save a life, that would keep a family whole, that would continue to and add stability to that family. So I'm just wondering if you could just talk a little bit about that, because it's just so incredibly frustrating that we just haven't made any headway, it seems, when it comes to touching the folks in the neighborhoods who need the most touching. So can you talk about that just a little bit?
Sure. And first, let me just thank you for all of your interest in health and your support for our health initiatives. I couldn't agree more that health disparities are a particular thing we need to care about here in Philadelphia. And there are several reasons for that give us some opportunities to try to address the problem, even if we can't eliminate that. One of them is that people who are low-income minority are living in neighborhoods where there are just less healthy conditions. Mm-hmm. The stores that are there are more likely to be selling tobacco, more likely to be selling unhealthy food. And we're trying to change those conditions so they have the same access to healthy products as people in high-income neighborhoods. The second is that they're less likely to access primary care. And so we're trying to make primary care more accessible and to encourage people to use services like treatment of hypertension that might prevent a heart disease, or use smoking cessation counseling like we can offer in those services. The person you talked about is a member of the demographic that has the worst health statistics entirely. That's black men, and that's why we've tried to draw attention with their Health of Black Men report. And men in particular, but black men even more so, tend not to access primary care. And so this is really a call for them to work with us to use the services that are available. Having said all that, we are making progress in the city. People are getting healthier, but the gap is not necessarily changing. Everyone is sort of getting healthy at the same rate. So we need to do more on both neighborhood conditions and primary care. And then there's the final issue of poverty is always going to end up having ways of causing more disease, and through mechanisms that are complicated and that we can't prevent. But so the efforts of the City Council to work on poverty and the efforts of the rest of these HHS agencies to address poverty ultimately will have a health benefit.
Well, obviously poverty is a factor. One of the things that I recognize, I'm a member of Enon Tabernacle Baptist Church, and for the season of Lent, we do a fast called the Daniel Fast, which is essentially vegan, no dairy, no meat, and nothing with a mother, we say. And so one of the things that I realized, and I usually do it every year, this year I was not as good as in past years, but I'm going to pray on it. But anyway, just recognizing that it's expensive to eat healthy. Eating healthy costs money. And so for us to recognize that poverty is an issue related to a healthy lifestyle, and yet a healthy lifestyle costs money to be able to get there, I just feel like we really have to try to do something different. If we're really serious about making a difference in the lives of everyday Philadelphians in neighborhoods that are normally untouched by what's happening downtown, then we have to do something, I think, just dramatically different to try to, and I know that there have been different sort of experiments of, having healthy fruits and vegetables in corner stores, and, I think that there was some moderate success with that. I don't know if that's still occurring, but it's certainly easier and cheaper and faster to find fried rice and 3 chicken wings than it is to find fresh fruit in the neighborhoods. So I don't know if we have anything that we're doing to address those sort of access issues. Even though we don't have as many food deserts as we used to have, we still have the same problem of access.
Yeah, so actually there's 2 problems there. One of them is that there's less access to healthy foods. The other is there's an overabundance of unhealthy products. They're out there actively promoting the products that we know kill us. And so, we worked with you and others, for example, in Stop and Goes. Those are the worst example.
Right,
They're selling these addictive drugs.
Right.
But we're also trying to reduce smoking outlets, and we are succeeding in reducing those in low-income neighborhoods. So yes, we need to do more to make people have accessibility to healthy products. And then while we're trying to work on poverty, so people have more money in their pockets so that they can buy them when they have that opportunity.
Okay. Let me ask you a couple of quick questions. Oh, do I have time? I'll come back around.
Okay.
Thank you, Mr. Chairman.
Thank you, Councilwoman. Doctor, I have a few questions, and I too as well want to thank you and your team for being very cooperative on issues that are brought to our attention, and programs and initiatives that we really want to try to have positive outcomes, or how we can help partner into the positive outcomes. So, one, in your testimony, you have a decrease of grants, $3.8 million. Could you explain were they one-time grants, or were they grants that are just not available, or were they federal grants that aren't available, and what the purpose of the grants were for?
Let me make sure we have the right number you're referring to, so I can give you an accurate answer. Can you say where it is in the testimony?
Page 3 in the budget detail. And the appropriation is down by 3.8.
Okay. I'm going to turn that over to Sammy Jura.
Yeah, Sammy Jura, Deputy Commissioner, Chief Operating Officer. So you're right, you see a reduction of $3.8 million in appropriation. If you look historically, our appropriations have been far higher than our expenditures, and what in the grants revenue fund, what appropriations means is permission to spend grants when awarded. So this is us making more realistic what we expect grants revenue to come in. You've probably not surprised that there are several agencies that are cutting back their funding, CDC, EPA, and so this is us being more realistic with what grants we expect to come in.
Okay, so some of those grants carry over?
Yeah, most of our grants are multiple years, that's right.
Okay, so the grants are available, you're just being a little more prudent on the appropriations?
That's right, yep.
Also, what effect has the opioid epidemic had on our medical examiner's office?
Well, it's made them a lot busier. There's many, many more autopsies they have to do. On an average day, we have 3 to 4 bodies that come in from drug overdose. We've had to hire an additional medical examiner to keep up with the autopsies because there's only so many that they can do, and to stress the rest of the staff as well.
And what's the overtime in the medical examiner's office until, is the additional staff or medical examiner cutting down on the mental stress and work hours that, the staff that occurs due to the lack of staffing?
Yeah, I think that's right. Certainly overtime usage in the medical examiner's office is high because of weekend and evening hours that are required. We're piloting something in fiscal year 20 to hire staff to accommodate the more realistic schedules that we expect will be needed ongoing in light of the epidemic. So we're hoping to see a reduction in overtime in the medical examiner's office next year, but you're right, that is the reason for that overtime.
And how many vacancies do we have in the health department? And what is there a plan to either fully fill the vacancies or, reach or have goals for, practical staffing,
Yes.
filling of the
I'm going
positions?
to let Mr. Draw give you the exact numbers, but there is always a fair number of vacancies in the health department because we have many different very specialized positions. For example, air pollution engineers and mammography technicians. These are positions that are hard to fill and take a long time for us to fill them. And so it ends up being that there are, at any point in time, a fair number of vacancies in the books. We don't budget, though, according to the number of total positions. We budget according to how many we think are going to be filled. So we allow for the fact that there will always be a certain number of vacancies. So it doesn't hurt the budgeting, but there's always a fair number. We can get the exact number to you.
Yeah, so I echo everything Dr. Farley said. The other piece I'd add, so to answer your specific question, we have 897 positions were filled of 1,050 budgeted in our last fiscal year, so that's a little north of 100 positions that were vacant. In fiscal year 20, we're trying to, again, like in the Grants Revenue Fund, sort of right-size that. So we've reduced our positions by 25 to try to be more realistic with what our actual filled positions look like in the budget.
So how is the HR department trying to streamline and help either recruit, depending upon the specialty? Because the city has, and I'm not just asking the health department, I'm asking, all the departments. We just had this conversation with, Parks and Rec. You have, vacancies and civil service. I mean, there's hundreds of jobs in the city of Philadelphia that remain vacant. And I think the city is really trying to advocate, for a more of a streamlined process to fulfill the needs because we need to. I mean, after years and years of great recessions and cutbacks, when revenues are down and the economy is slowed, the first that goes are people, unfortunately, and we can't cut any more people. Right? So we're in a need for professional, non-professional, skilled, non-skilled workers here in the city of Philadelphia. So, I'm just asking people, how are we going to fulfill our responsibility for the professional services and or the vacancies that remain to be filled in a systematic way that helps management of not only supervision, but to keep our core services and social services at the high quality that we deserve.
Yeah, so we have identified in the past that the slowness of filling positions has been a problem for us. And so one of the things we did was we recognized that all the different approvals and sign-offs and communication within the health department was a paper process, and that things got lost when someone was out and no one knew where that piece of paper was. And so we've actually had a vendor develop software for us to take someone from the time a position is a division wants to hire till the time a person is actually hired, have that an electronic process so that everybody could tap into it so we can speed up that process. And that software, by the way, is available to other departments if they're interested in using that, and that would help maybe defray some of the city's costs on that. As far as the specialized positions that we are always having trouble filling, we have established a position within the HR department specifically around recruiting to try to say, how do we communicate with people who are, for example, radiology technicians or something that very specialized certification, make them aware of the availability of the positions in the city and take advantage of those. And we're also trying to use that to circulate information to people about our more common positions, such as program analysts, so that we get a higher quality applicant to those positions. But recruiting is a clear focus of the HR department, along with the software to try to address that problem.
So, do you advertise publicly all the vacancies and the job positions
yes.
that are needed? So roughly 75 to 100 positions are being circulated as a help wanted ad in recruitment. Is that correct?
Yeah.
Yes,
Yes.
we do.
Okay.
Now, are most of the positions civil service or exempt?
Regular civil service.
civil service. And I know not only do you have to fill your own positions, you're also supporting HR and other positions, with the city of Philadelphia. How is that going, like with testing and going through, I guess the examination process, or, when you get physically cleared, to, enter into the job force in the city of Philadelphia, whether, it's blood work or other kind of testing. Is there been how is that? Is that going smoothly, or has there been a slow kind of, support on that?
I'm not sure I understand the question. This is about the unit that does a physical exam
Right, so
for people.
what I'm getting to is not only do you have to fill your own jobs, you have to help support filling hundreds of other jobs in the city.
We don't
You don't have to
manage
do
that
them?
unit anymore. That's managed by a central office of.
Of central office, so I thought the health
Yeah.
department had to, do checkups for, like our
No.
police and our fire, and, getting like TB shots and.
Yeah, I think that may have been in the health department in the past, but that's not part of the health
Oh,
department now.
it isn't anymore?
Yes.
Okay. I'll defer my questions for the next round. Chair recognizes Councilman Thom.
Thank you, Mr. Chairman. Good afternoon.
Good afternoon. Just me.
I had some general budget questions that maybe you could just shed some light on so we can understand the numbers. And looking at the budget in fiscal 2018, the actual obligations for public health were $353 million, if I'm reading this correctly. This year, there's $645 million, a $290 million increase over 3 years, or 83% increase over 3 years. And I noticed that one of the big pieces of the increase, or almost half of the increase, is in the area of purchase of services, which is about a $145 million increase. Is that the Philadelphia Hospital Assessment reauthorization?
Yes, the Philadelphia Hospital assessment is proposed to be increased, and that's money that doesn't stay in the health department. We basically assess it and pass it on.
Okay. And how does that get used? How is that going to be utilized?
It's the basic idea is the hospitals are assessed a fee, which then goes up to the state through the city, and then they receive that fee with additional federal dollar match back to the hospitals, so that they have a net positive financial advantage as part of that arrangement, and then the hospitals use that for whatever services they feel is necessary.
So this is like a windfall for the Philadelphia hospitals of $150 million?
Yes, it's a support for the Philadelphia hospitals. The federal Medicaid program will match dollars that are spent, and this is a way to increase that federal match, to draw down additional federal dollars.
Now, I understand it doesn't cost the general fund any money,
Yes,
but it's really the hospitals in our area will get an extra $150 million, and we really don't know how they're going to use it.
it's up to them how to use it, yes.
Let me just say one minor point, that the services are for Medicaid patients. So there is a stipulation that when the hospitals receive that payment back, it's for Medicaid services in their hospitals. And the assessment that the hospitals are assessed by us as the city is based on their volume of Medicaid services as well.
Okay, and so that's basically half the increase of the 83. We're still at 41.5% if we take that out of the equation. And so one of the areas I had is this payments to other funds. This was 34,000 3 years ago, and today it's 21.5 million in the proposed budget.
Yeah, so that, most if not all of that is money from the Volkswagen settlement. For those people who don't know, Volkswagen got caught cheating on emissions, and so they have to make money available to localities to replace some of their older vehicles and diesel generating equipment so that it doesn't produce as much air pollution. The grant money for that is expected to come through the health department and will be used for purchasing additional trash compactors. And I believe there may be some from buses for SEPTA, and there may be additional chunks of money that's going to come down the line as well. So none of that money stays in the health department, but that is money that is going through the health department,
Just
therefore it
funneling
appears in the
through,
budget.
I understand, but
Yes.
can we make sure that we use all that money?
Absolutely.
Okay, so that means that the additional dumpsters that don't have to be in the general fund budget, they can come through the 21 million?
So I'll say so this is all a grant program administered by the state that has really specific stipulations in the Volkswagen settlement agreement. So we applied to the state for this funding. One round has been offered, and we've, I think, applied for up to $6 million or something for trash compactors and fleet used across the city. So the idea is to offset the cost that the general fund might experience to replace these sort of old diesel-emitting machines.
Right, but if we're going to use the money from public health to help fleet management, for example, that should lower the budget of fleet management.
Within the narrow confines of what the Volkswagen settlement allows, that may be possible.
Yeah.
But it's possible that some of these existing equipment isn't at the end of its useful life, but we're replacing it to reduce air pollution. And so it may not necessarily reduce the expenditures by fleet.
I see the budget director's coming in.
Hi, I'm Anna Adams. I'm the budget director. We actually assume that in our budget that
Of
we will
course you did.
receive
Yeah, I'm
the,
sure you did.
the
Right.
Volkswagen. So we build that around it. So when we put the capital budget together, we have some assumptions about what will come in from the Volkswagen settlement, so that we don't have to add any more GO bond borrowing. So we kind of build that in as part of our context. So it's not that there's money that therefore we can swap out. We've already swapped that out when we built the budget together.
I wouldn't have expected any other answer. Thank you. Another question on the budget, the purchase of services. I realize this is just grant money, correct? But the increase is pretty dramatic, 63 million 3 years ago to 100 million today. And this, I think, coincides with Councilman Heenan's questions on why some of this is going down. But what is that money going to, $37 more million the last 3 years?
So most of that increase is Volkswagen. So 40 million of the increase was Volkswagen. It was put in that line you saw, payments to other funds. And then, so that was about 20 million, and then an additional 20 million in that purchase of services.
Went up
so
to,
40 million
it was
was
split
put in for
between two
Volkswagen.
categories.
That's right.
So we're getting $40 million from the Volkswagen.
So in the grants fund, appropriations means permission to spend if
I know.
granted. So
If we don't spend it, do we lose it?
we reappropriate it in the next year. We don't lose it.
Okay.
Right.
Let me go to my other questions for a moment. Does your department handle its own IT services?
Yes, we do. I mean, our IT director has an official position within OIT, but she sits in the department.
So would there be any benefit to consolidated your services under OIT?
We don't think so. We don't think that there would be efficiencies gained there, and we are a very heavy user of IT services. A lot of our work is collecting data, analyzing that data, and putting that data out to people. And so having the ability to control our own IT systems, we think, makes us more effective.
But you're like the second or third department that's been here that has their own IT, not coordinated under OIT. I'm just wondering if there's a benefit for the city to all these IT people to come together under OIT.
Again, IT is very much just integrated into everything we do, and so we think it's really important for us to have that closeness of having them in the agency so that we can do our work well.
Okay, thank you. I'll come back on the next round. Thank you, Mr. Chairman. Thank you.
Chair recognizes Councilwoman Bass.
Thank you. Good afternoon again. Quick question for you. Well, two questions, actually. So just looking at your budget summary, can you discuss why minority participation, MWDSB participation goals were at 30% in 30% in fiscal year 18, 40% in 19, and dropping to 32% in 20?
Let me just, there's only a few contracts that we have that are put in that category. One of them was for radiology services. That was with a minority contractor. That service was purchased by Jefferson, and Jefferson is not a minority contractor. So although we didn't change what we were doing, it ended up changing our statistics there.
Okay. Okay, so that's really what that accounts
Yep.
for, that
Yep.
8% drop in minority participation?
Yep.
Okay. Are there other ways that we can make up minority participation through contracts? I know you said you don't have a lot of contracts, but among the other contracts that you have, are there ways that we can address ensuring that we have some more robust numbers when it comes to participation in goals?
You know, we're always on the lookout when we contract with for-profit contractors, which is not that often. But when we do, we're always on the lookout for minority contractors. For example, we do mass media services and a variety of communication services. So we put out a request for proposals in the past year to get a number of contractors that could provide the different services we have and have them available for when a need arose. And we were very attentive of that through that process to get minority contractors as part of the pool that were funded.
Question for you on African American women and maternal mortality. A few months ago, I introduced a resolution calling for hearings on the increase in maternal mortality among African American women in Philadelphia. Black women comprise 3/4 of all pregnancy-related deaths in Philadelphia between 2010 and 2012. A maternal mortality rate of 53% higher than the national average, and it's rising. And so I just wanted to know, I didn't see that there was any strategic plan to address this by the city's health department. And so I'm wondering, is this a part of your strategic plan? Are there goals in trying to address this? And it's not in the budget material. So is there a plan for that?
So, there is a rise in mortality among pregnant women in Philadelphia. It's not necessarily what people may think. In rough numbers, in the past year, we had 25 women who were pregnant who died. The number 1 and 2 causes of mortality among pregnancy were drug overdose and homicide. So it was associated with pregnancy, but it wasn't related to pregnancy. It wasn't the pregnancy itself that killed them. The number of women who died from pregnancy-related complications themselves ended up being about 5 out of the 25.
Say again?
Ended up being about 5 out of the 25 that it was the pregnancy itself that caused the mortality.
Okay.
So we want that number to be 0, but it's a small number to work with. Every pregnancy-associated death is reviewed by a panel that is operated within the health department to see what could have been done to try to prevent this death and what can we do differently. That panel represents or has representation from the different hospitals in the city that provide maternity services. So we're always working on how we can reduce that. That 5 is a hard number to reduce. The larger number is really these other social problems that are now showing up in pregnancies, the same thing that's killing other young adults, unfortunately. And so we need to think about how we do a better job of preventing drug overdoses and how to do a better job of preventing homicide in those folks.
Okay, all right. I hear you. I do think that, we might want to consider, because we see that it's specifically related to this particular group of women, that there's something that might be done. And I realize that, like 25, I don't know how many babies were born in the city of Philadelphia last year, but, 25, deaths may not be considered an emergency unless, you're one of those 25, you're related, you're connected somehow to one of those young women who lost their lives. So I would like to see if the city of Philadelphia could do more around, having a more of a sense of urgency when it comes to, again, underrepresented, underserved populations who haven't really been, paid attention to. And if there is a way that we can address homicide, and did you say that was related to domestic violence primarily?
No, drug overdose.
Well, drug overdose, but on the homicide.
Drug overdose and then homicide, yes.
Drug overdose and homicide, but not necessarily domestic violence?
Yeah, I don't know how many of those homicides were domestic violence versus people shot on the street.
Okay, all right. So, but again, if there's more that we could do, then I think that that's something that we should be looking at, because those numbers are just absolutely unacceptable. That is 53% higher than the national average. I think that not only is it appear to be dangerous for African American women to be pregnant in Philadelphia, but it does put a stain on this great city with all of these resources and access to health care that were 53% higher than the national average. I don't think it, is a good reflection of our city and anything that we certainly would want to not address. Also, I wanted to ask if you could talk about HIV rates here in Philadelphia, and we've met with several HIV advocacy organizations, and we know that rates are rising, and There's not enough people talking about it. There's not enough people who are sort of acknowledging it. There was one time when HIV sort of first came on the scene, and it was, a death sentence, and everyone was frightened, and, there was just all this concern. And now that there are treatments, more effective treatments, which still don't prevent death, but, prolong life and a much better quality of life, I'm wondering, does the city have, any ideas in terms of addressing HIV rates and the increases here in Philadelphia?
Yeah, so the good news on HIV is that the total number of new infections per year does continue to fall. We've had, in 2018, current count is 413 new HIV infections. That number may rise when we come up with a few more, but it's a couple years ago we were around 500. However, what you may be alluding to, HIV rates among people who inject drugs has been rising, and that worries us quite a bit. It's gone up from about 30 to about 60 over a period of a couple of years. Mm-hmm. And that's related to the opioid crisis and the sharing of needles around that. So the department has really worked to try to address that problem. More testing among people who are using drugs, more education, more partner notification, more efforts to try to get them into care early, as well as get them to provide preventive medications. We're continuing to work on the other populations where we have been seeing progress, and we hope we'll continue to see progress. But I think that's the biggest threat over the long term, and we need to continue to watch that closely.
Can you just, I know my time's up, but I just want to finish out this last question. If you could just give us some sort of a demographics on, I know you said it's among drug users who inject, their drugs, but can you give us some idea in terms of the other segments of our population and what the HIV rates and new transmission rates are?
I can tell you that the largest risk group is men who have sex with men. And then the second group would be people where transmission was through heterosexual contact, and the third group would be injection drug users. I can get back to you on the rough numbers for those three different categories. To your point about demographics, though, it clearly is heavily tilted towards African Americans.
Say again?
It clearly is tilted towards African Americans in all of those categories, and that's something which we don't find acceptable. And so we have specific efforts to reach out, for example, to African American men who have sex with men to reduce HIV transmission. And we're making progress, but we want to make it faster than we have so far.
I'd like to get those numbers so we can just
Sure.
see how far and wide it stretches, because obviously there are some men who have sex with men who also have sex with women and who may not know that they are infected.
Absolutely.
And which can set off a real cycle. And that again, this is another issue with the number of people infected with the HIV in the city is 5 times the national average.
Yes.
So I've been told. So again, in a city of eds and meds, it's like some of these things really just should not be happening. But I'll come back around to my next level, my next questions.
Thank you, Councilwoman. I have a few questions. We were talking about Health Center 10, which is in my district, and they are extremely, extremely busy and doing a fantastic job, even though we've cut down the wait time and offer some other services, and I think we're hoping to expand at some point, even at a different location. But at one of the most recent announcements that we had, and you might have mentioned it, is it your health roadmap to health, or access to
it was our Staying Healthy
care.
report, which is about
Right,
access to
Staying
primary
Healthy.
care in the city.
So,
Yes.
how is that? What progress have we made? Because we're talking about access to health care is when it comes to proximity to people, as opposed to not having health care and utilizing 911 or emergency rooms as their primary doctor and for their primary care. So how has that access to care changed, even in little bits? Are you able to measure it?
So the report that we put out showed that there were pockets in the city that particularly had low access to primary care that would meet the federal government's definition of a healthcare shortage area. In particular, they were in the near northeast and in the southwest. We put that report out a few months ago, and we're going to be doing updates on it annually to see what progress is made. Progress is slow in general in this area. It requires opening up a new facility or building a new building and staffing it up. And so we don't expect we're going to see big changes year to year. I do know that there is one additional federally qualified health center that is planning to open in the Northeast. I don't think that's going to make a big difference because it's relatively small. So probably we're not going to see big changes in the past year.
Because, the underlying, issues, preventative diseases and access to care will help prevent, sudden death, or, somebody having, diabetes or, cardiovascular issues as a result of, having primary care. I'd be curious to see after each year, the baseline to see, what kind of measurements has changed and how quickly it changes, or what we need to do to modify or tweak it as we move forward. Which leads me to how are we, childhood obesity, as you well know, worked with the department and other city agencies, at Department of Recreation, primarily with the childhood obesity program called Philly Play, now Play Philly, that's in our summer camps, or a lot of them. And we started out in 2014 in 10 rec centers. Now last year was 70. We're going to be well over 100 this year moving forward. And it's about education. It's about introduction to healthy foods. It's about, explaining what food insecurity is and how to stay active for 60 minutes, and the importance of staying active for 60 minutes while everybody's, on one or two phones and screening in the basement, hanging out with their friends online instead of, out in the street, on the sidewalk or our rec centers. So, we're really trying to lead by an example, with the program and in educating our youth as they grow into healthy adults, and that is the goal and the outcomes that we're looking for. What is the health department doing, or how are they supporting the childhood obesity issues that we have here in the city?
Yeah, so first, thanks for raising that issue. We talked about heart disease and cancer being the leading killers, and the early signs of that do appear in childhood with obesity that leads to diabetes and those other complications. And so the health department is working on both the physical activity side of that as well as the healthy diet side of that. On the healthy diet, probably the most important thing is something the City Council did, which was the Philadelphia beverage tax, which has led to roughly a 40% decline in consumption of sugary drinks, which are a major contributor to childhood obesity. And as you heard earlier, we're trying to make access to healthy food more widespread. And we're trying to incorporate physical activity into things like recreation centers, working with the school system on physical activity. And we have a media campaign out there called Philly Powered about how people can get access to physical activity programs and incorporate physical activity into their daily routines. None of it is easy. Nobody in the country has really turned around the obesity epidemic yet, but we're doing everything we can do that.
Yeah, I know nothing's easy, and
Right.
I think it comes down to what is our priority, all right, and where are we going to spend our resources to have a positive outcome in rate of return and, preventative diseases and, hopefully prevent, sudden cardiac arrests. I think we have 1,000 sudden cardiac arrests a year in Philadelphia alone. What part of that could have been preventative? I'm not sure, or prevented, and what are hereditary or genetics? I don't know who's more likely to be disposed to that, from genetics, but we certainly have the ability to change some of the behavior in young children as they grow into young adults, and then hopefully we cut back on that 1,000 sudden cardiac arrests. Cut it in half, because these young children are being exposed to, what it's like to be healthy and why we need to, live healthy lifestyles. Right? Because if 60%, I'm going to say, well, you know what? Let me ask you the question, because I start throwing out numbers, I'm going to be wrong. What is the percentage of, so children in the city of Philadelphia, childhood obesity is roughly 35, 40%. Is that close or approximate?
I have to get back to the exact number. It's
Right.
certainly a high percentage of children.
So what I'm going to ask, and you can just respond to the chair at another time, a breakdown of childhood obesity and adult obesity, all right,
Sure.
or overweight. So I think between adult obesity and being overweight is over 50% and near 60%, all preventative diseases. Not that I practice what I preach, but there are some reasons, that kind of that kind of go with being a city in an urban city with 26% poverty in certain areas. And I'm leading into my last question for you with childhood obesity and overweight and adult obesity. Have you identified the health department? Have you identified predatory marketing, all right, on products and what products they are? And if you don't know them, have right offhand, I know you had mentioned one, but could you provide that to the chair? Because I believe that people can make money, and I wish people would make as much as they're smart and well thought out business, but not at the expense of people dying or workers in the city of Philadelphia. So my ask to you is, could you put together some sort of analysis of predatory marketing, where it is and what the products are, and you could directly correlate that with unhealthy outcomes?
We'd be happy to send you a report on that. Just to throw out some numbers here, roughly 35% of adults in Philadelphia are obese. Maybe another 35% are overweight, so 70% are either overweight or obese, so that's a huge fraction. And that is, the most immediate consequence of that is diabetes. We have an estimated 135,000 people in Philadelphia now who have diabetes. A decade ago, it was maybe 85,000. And it's so common that people almost think it's part of the normal condition, but it's not, it's a disease. And absolutely, we think that the food industry in particular markets foods that are particularly likely to cause obesity and diabetes. We try to counter that with our communications around things like sugary drinks. We're going to be talking more about sugary snacks. And those are marketed in general more in low-income neighborhoods than in high-income neighborhoods. And that's part of the reason why those people are more likely to suffer from diabetes and its consequences.
Okay.
But we'll get a report to you.
All right, great, thank you. Chair recognizes Councilman Dunn.
Thank you, Mr. Chairman. Good afternoon again. A few more questions. According to GuideStar at the Philadelphia Nursing Home, 99.5% of the residents are covered by Medicaid or Medicare. Why is the general fund paying $47 million for this program, or about $125,000 a year per person?
I'm going to start and then I'm going to turn it over to Mr. Giroir. The general fund, I don't think, pays that entire amount. We receive the Medicaid revenue. The Medicaid revenue almost, but not quite, covers all of our expenses. So we do draw down the Medicaid revenue.
Are we getting fully reimbursed?
Almost fully reimbursed. So Medicaid and Medicare provide something like $35 million a year in revenue from the nursing home. So there is a small general fund investment beyond that. It's a safety net nursing home, but most of its services are covered by revenue received.
So how much is the shortage that's occurring?
From memory, it's maybe 3 to 5 million.
And I'm just curious, why is it $125,000 a person?
Say the question again.
So it comes out to $125,000 a person based on your 99% occupancy. Why is it so expensive?
I'm guessing that that's probably on par of what nursing home care costs in other places as well. And it's not that much different doesn't operate that much differently from other nursing homes. That it's fairly intense care. If you've been there, these are people who have a variety of conditions. They may have had gunshot wounds, and so that they are paralyzed. They have diabetes. They may have behavioral health problems. So it needs a fairly intense amount of care.
Okay. Page 11 of your testimony, you showed for-profit vendors that were contracted with your department. It seems that only one of the vendors were local.
I'm sorry, this is on page 11.
Yeah.
See, which one are you seeing that is, that you believe is local?
Well, it looks like most of them are not local. That's my point.
Yeah.
Is there any way to look at that going forward and figuring out if we can utilize the local vendors in Philadelphia?
We'd be happy to give you information on that. I think there's more than one of these that are local. We'll get back to you. I think the
Okay.
majority of them are.
Okay.
We'll get you more detail.
And then just another question. According to Medicare.gov, we received 1 out of 5 stars for health inspection of the Philadelphia nursing home. I'm just curious why the reasons this score was received.
Yeah, before that year, the nursing home received, I believe, 4 stars or 5 stars. What happened was that the state of Pennsylvania, which inspects nursing homes, changed their inspection process, where they randomly selected a small number of residents and looked at their history in great detail, and a number of individual factors could quickly reduce the number of stars. And nursing homes all over the state saw a huge reduction in their star rating. And so we have, one of the contracts here is with a consulting service that goes through with a nursing home to try to figure out how to improve their rating and how to address the deficiencies. The rating, my understanding, has gone up since then, but this was a statewide phenomenon.
So we're working on getting that back to the 4 to 5 stars?
Yes, we are.
Okay. Then another question. The capital budget includes $800,000 for your department in fiscal year 20. Any idea what that's for in the capital, 800,000?
Can you give us the exact place you're looking at it so we know we're looking at the right number?
It will be in the capital budget. I don't have the exact page,
Okay.
but it says 800,000 for your department in fiscal year 20.
Yeah, so almost all of our capital budget is used for maintenance at our health centers. And the big project that's happening now is addition of exam rooms at our Health Center 10 in Northeast Philadelphia. So
Okay.
we're adding pediatric exam rooms in the basement, added an elevator, and added more exam rooms.
All right, let me just go back to the question you answered before. So I just want to make sure I'm fully knowledgeable about this Philadelphia hospital assessment issue. So this was a huge increase of $150 million a year. And just explain again to us how this happened and where the money goes and how the hospitals will utilize it.
So I could say a little bit about it, and I'll also say I think we're coming before the City Council Finance Committee in May for the renewal of this hospital assessment, so we can speak more there too. The $150 million increase is almost exclusively a rebase of a new, more current year for hospital revenue assessment. So the assessment as it's existed was based on Medicaid revenue for calendar year 2010. Since 2010, the Affordable Care Act has happened and Pennsylvania has expanded Medicare. So the Medicaid volume of services and revenue in hospitals has increased dramatically since 2010. So the hospital assessment renewal that will happen this year is based on 2017 data. So that's almost exclusively the reason for that increase.
So is this money going to these hospitals that's basically helping them cover their expenses? Is that the issue?
Right.
And so and on a separate note, I mean, is this a help to like Hahnemann that we read about that's having some problems? I don't know if you can comment about that or not, but that's a concern, I think, of everybody. Like, what's the future of Hahnemann?
Yeah, so Hahnemann does participate in this program, and so, through this program, they would receive additional revenue from the state.
And do you have any comments on how we're going to keep that hospital? Does it look like we're not going to keep that hospital?
I can only say that we've been part of discussions. We know that they have troubles, and that the city is continuing to discuss with them to see what can be done.
Okay. All right. Thank you very much. Thank you for the work you're doing, and thank you, Mr. Chairman.
Thank you.
Thank you, Councilman. Dr. Farley, we had touched on childhood obesity. We talked about access to primary care. We talked about outcomes and obesity. You had mentioned we also discussed briefly about the predatory marketing and or products that contribute to a lot of these preventative diseases. You also mentioned a decrease in consumption of basically beverages, right, sugary drinks.
Right.
What is the decrease in children in some of our more impoverished areas. And what does that mean to the kids?
What is it, decrease in what? In their obesity rates? In
Consumption of sugary drinks in those areas, and what does that mean on, to them and their outcomes?
Right, so the overall consumption, you think of it in sales, or consumption in adults is down about 40%. We do have data from teenagers from a survey that was done just shortly after the tax went in place that saw a reduction in teenagers, particularly among African American and other minority teenagers, consumption of sugary drinks. There's no question that that should, over the long term, help reduce certainly any rise in obesity, because we haven't turned it around negative yet, and have other health benefits. We don't yet have information about consumption in in children under the age of teenage children, and we need more surveys to look at what the longer term trend is in teenagers. But we're optimistic that this will really make a big difference in their consumption.
So what is the decrease in teenagers? You said you do have those numbers?
Yes. Let me see if Cheryl's here. She's over here.
But you don't have it below teenagers, right?
We don't have information below teenagers. There's a survey done in high schools every other year where this question is asked, and so we have data from that survey. So among the heaviest users, 3 or more sugary beverages per day, there was a 30% reduction in that percentage.
For teenagers?
Yes, for teenagers.
And I would imagine, the trend would be, maybe less, but it would be similar trend in, toddlers or
I think it might be an even greater impact on children because the tax also raised awareness about the risks of these beverages. And so the first thing that parents do in general when they think something is unhealthy is to stop feeding it to their children. They care about their children's health more than their own. So I think that we should get real benefit out of that tax on beverage consumption in children.
Okay, my last question, just to, Councilman Dom had mentioned hospitals. I just, read in the paper about Hahnemann. It seems to be, of great concern, I think, to the people of the city of Philadelphia and towards partners and schools and universities. I just want to make sure, or know that the health department administration is watching it closely and making sure that we don't lose that kind of care service right here in Center City.
Yeah, I can say we are fully engaged in the discussion, as is the entire administration.
Okay, great. Chair recognizes Councilwoman Bass.
Thank you, Mr. Chairman. Just a couple of things I wanted to follow up on, and the first is just going back to the, the talk about the sugary beverages, sugar-sweetened beverages, right. Because, it just drives me a little crazy that, soda is like the answer to all of our problems health-wise. It seems as if we can remove soda and not replace it with healthy options and still not address the consumption of fried food, fatty food, of the Cheetos, the Doritos, the Tasty Cakes, all the other O's, if you will, that people are consuming in the neighborhoods, and we've removed one product, or not even removed it, but we basically, put a tax on one product, and all of a sudden, we're expected that the outcomes are supposed to be significantly healthy for an entire population. I just think is a little bit, incorrect. I'll just say it's incorrect, in my opinion. So I just wanted to add that to the conversation, but also I wanted to ask you about Hahnemann as well, because one of the things I've been doing as a chair of Health and Human Services is visiting all of our hospitals and medical facilities here in Philadelphia. And one of the things that really struck me, I went to Temple's emergency room probably in the last few months. And one of the things that really struck me is how they don't have enough space. And, as I was talking to the doctors and the folks in the ER, they said that when the hospital was built, it was built for a particular capacity. and they were able to maintain that capacity as long as, you know, Women's Medical was open and other surrounding facilities were open. And then there was a ripple effect when those facilities closed, and now Temple has a significantly higher, you know, population that's coming in through its ER that the hospital was not built or intended for. And so they're trying to now figure it out on their own. So I want to join the chorus of others in expressing my concern about Hahnemann, because there will be a ripple effect if something should happen, if Hahnemann should close or downsize or anything of the sort. And I really even hate to say it because I don't even want to put that into the atmosphere. But I don't think that we should diminish what the ripple effect on the other neighboring institutions would be here in the city. So.
Okay, thank you. I have not been to the emergency department at Temple, but I hear your concern.
Well, yeah, it was a great tour, and shout out to Temple University Hospital and all of the hospitals in Philadelphia who are really doing some great work. I went to Temple, I've been to CHOP as well, and they are just doing amazing work. All these facilities, also Fox Chase Cancer Center, in terms of the research that we're doing here in the city of Philadelphia and the impact that we're having, and the energy and the excitement around the researchers who feel that we are just so close. We are so close to being able to address so many things that ail Philadelphia, that ail everyone. And so it's very exciting to see. So I just want to recognize them as well. Back to my questions about HIV. And I wanted to ask you about the department promoting and increasing awareness of pre-exposure medications, treatments, things that are available to prevent HIV. And so what is our outreach, knowing what our target population is, who is most likely to be infected? What is our outreach and response to this crisis?
Yeah, so pre-exposure prophylaxis, for those who may not know, is a pill that people can take every day which prevents infection from HIV if you're exposed to it. And it's recommended for people who are at risk. Obviously, for someone who's a part of a couple where one person's positive and the other one's negative, or other people who have high-risk behavior. And our AIDS unit is working hard to make that medication available to a variety of different healthcare providers in the city. We make it available at all of our health centers.
Is there a cost to it?
Not a cost to the patient at our health centers.
Okay.
And so if people have insurance, the insurance can cover it, and there may be even financial assistance for people who are uninsured. And we have a specific PrEP clinic at our health center number 1 for people who come in regularly, and we monitor them over time. And there's a variety of other providers out there who are either funded or encouraged to make that available.
Where's health center number 1?
Health Center number 1 has just moved to Constitution Plaza. It used to be at 500 South Broad Street, and is now at farther south on South Broad to what used to be St. Agnes Hospital.
Can we have the same services offered in all of our health centers?
Oh, it is available in all of our health centers.
Okay.
But there it's more through regular primary care physicians. But in that place, it's a specialized PrEP clinic for people who just want to come in for that and may not have a primary care physician. So we have both.
Okay. Okay. Question about asthma hospitalizations. And I have Nicetown in my district, which has some of the highest asthma rates in the city of Philadelphia. It's my understanding that the department has been working to reduce asthma hospitalizations by having Medicaid plans in the city pay for community health workers to go into homes and conduct home-based environmental remediation services. And can you talk about that a little bit? One of the things that, again, struck me when I went to Children's Hospital of Philadelphia is that they're doing, in some cases, total home renovations around children who are regularly hospitaled around asthma, and who continue to come in, particularly in the West Philadelphia, the area, closely surrounding the hospital, because these children keep coming in. And so CHOP proactively said, well, what can we do? Let's go out, let's look at the environment, and let's get rid of, paneling, which may have mold behind it, or drop ceilings, which may have mold and moisture, or address the, maybe an infestation, which may be causing asthma as well. So can you talk about that?
Yeah, so asthma is a big problem in childhood here. It's the number one cause of hospitalization. It's particularly a health disparity, much more common in low-income children, much more common in African-American children. And it is, to me, basically a housing problem. It's housing conditions which cause asthma triggers that make the children have the problem. And CHOP has developed a program to remediate those homes and reduce those asthma triggers, which has been proven to reduce hospitalization. It's a national model. We think it's a wonderful program. And that's the program that we are trying to bring up, scale up citywide. It's been a long haul, but we've finally gotten most of the managed care plans here to agree to reimburse for that service if it's provided through the city so that we can supplement what CHOP is doing. And if that continues, we hope to ultimately scale that up to all the children citywide. Now, CHOP is adding to that service this specific home renovation for if there are housing conditions that are beyond what a community health worker can do. That's expensive. They're doing it for a small number of houses, maybe a dozen, and we'll see its impact. We're very eager to see that that's happening and love to see if it could be expanded, but ultimately it's funding that is the limiting factor here.
Okay. All right, and I think I have one last question for you. Can you talk a little bit about tobacco use in young people here in the city of Philadelphia? I know that, we've worked on, the issues around cigarillos and other flavored tobacco products. And, the Commonwealth has really restricted City Council's ability to pass new regulations on tobacco sales. And can you talk about what other ideas you might have to address these issues? I was recently at an event, and I saw some young people hanging around outside. And it shocked me that they were smoking, not because they were smoking, I guess, because, people smoke, but they seemed so young. They seemed, preteen, not even teenagers. They seemed like preteen. Maybe they just look really young. But what kind of things are we doing, can we do to affect youth having access to these flavored tobacco products in particular, which get them on the path to becoming a user of cigarette products?
Right. So I'm glad you asked. Tobacco was really the number one killer in Philadelphia. But the most recent ways of estimating maybe 3,500 deaths per year related to tobacco. There's some good news and some bad news around smoking among teenagers. Smoking of cigarettes among teenagers is now at an all-time low. It's at 3.5%. Not long ago, it was probably 20%. However, that's been replaced by is smoking of cigarillos and e-cigarettes. And both of those have health risks that concern us quite a bit. We worked with the council to try to restrict the flavorings in those cigarillos so they would be less appealing. As you said, the state legislature then preempted us. That was something particularly frustrating to us. So there's a real limit to what we can do legislatively at this point to prevent the kind of very irresponsible marketing that targets low-income and minority kids in the city.
Well, quick question,
Yeah.
because we know that, to really reach young people, you have to get them early. And if these folks look, like I said, say in the 12, 13-year range, do we do any contact with the school district of Philadelphia to bring sort of, anti-smoking advertising campaigns? Do we talk to young people? How are we reaching that next wave of customers that they're expecting to be able to get with these flavored products?
Yeah, so we are working with the school system, particularly these days. They're seeing more within schools e-cigarettes or Juul in schools. We are also reaching out to children through media campaigns, media messaging about the risks of any product that has smoke in it, whether it's a cigarillo, whether it's a cigarette or any other product. So yes, we're reaching them wherever we can. We also have the bill or the rule that the city has, which puts a limit on the number of outlets that can sell tobacco products, and that through attrition, that means that the tobacco marketing at point of sale in low-income neighborhoods is going down over time, and we're really pleased that that's working as it should.
So what are the numbers looking like now?
So we're falling about 9% per year. We started at 3,400 tobacco outlets in the city, tobacco permits, and that was in 2015, 16. We're now down to about 25, 30, so about 25% less. And that decline is mostly in low-income neighborhoods.
Can you provide a map to the council president in terms of what the original numbers were? I remember just the saturation map that you had given us, and can you give us an updated map so we can, visually get an idea of what the change has been?
Absolutely.
Okay, great. Thank you very much. Thank you, Mr. President.
Thank you, Councilwoman. I have around 38 questions for you. I'm actually just kidding. I want to thank you very much for your testimony.
Thank you very much, Mr.
Look
Council.
forward to continuing to work with you. Next up, we'll have behavioral health. Good. You're welcome. Oh, we're going to take around 10 minutes. 10 minutes. Good afternoon. Please proceed. And if you can kind of summarize your testimony best possible.
We get it.
Thank you.
Good afternoon, Council President Clark and members of City Council. I am David T. Jones, Commissioner of the Department of Behavioral Health and Intellectual Disability Services. Joining me today is Dr. Jill Bowen, Deputy Commissioner. I have submitted my testimony on DBHIDS's fiscal year 2020 proposed operating budget. I certainly would like to thank the DBHIDS staff, who a number of them are here today, and some are obviously back at the office, but for their acumen, their work ethic, and passion for serving Philadelphians. We also want to thank the provider network, also some of which are here today, for their commitment and certainly their provision of quality services. You have in your folders information about information graphic on accessing behavioral health treatment. There's information about the provider profiles along with a companion guide that explains the profile. There's information about the continuum of care, treatment care via community behavioral health. There's also information about DBHIDS's minority, women, and disabled on business participation. There's a flyer in there. And then there's fact sheets about how to access in terms of contact DBHIDS, fact sheets about treatment for opioid use disorder, and some information about our Faith and Spiritual Affairs Conference. We certainly appreciate the ongoing support of Council and are committed to narrowing the gap. With that, actually, I conclude my opening remarks, and we're available to respond to questions.
Thank you. Here's a question about in your budget detail on page 4. Received a $100 million appropriations for Health Choices Behavioral Health Fund, which is state funding. Do you really anticipate an increase in $100 million?
So we anticipate, that's more of an appropriation in the event that we have increased members, and so that's what that represents.
So my question is, do you anticipate increased members? I know we do the appropriations in anticipation of funding or hope of funding. So you really anticipate getting that, and that's based on the increase, what again?
So it represents actually increased enrollment. So,
okay.
You know, as you have, it's
and you
a health
anticipate
plan,
that,
right?
that
so
level
you
of
anticipate people coming in, right? We don't necessarily anticipate getting all of that revenue, but in the event that we do, we want to have.
You'll have your appropriations
correct.
authority.
Yeah.
Okay. All right. 8th and Girard. Who do I talk to about 8th and Girard?
Council President, what is it that you want to know about?
I think the person's getting up now.
Good afternoon, Eva Gladstein, Deputy Managing Director for Health and Human Services.
Good afternoon. How are you?
Good, how are you?
Okay, 8th and Girard. So we had a conversation several months ago about some additional clients, services, the whole 9 yards, and kind of went away, and then I understood you all were prepared to move ahead. I expressed some concerns at the lack of community notification, conversation, the whole 9 yards. Can you tell me where we are with that?
Sure,
And can you just, for those that have no idea what you and I are talking about, can you tell me what was proposed at the site?
Sure. Now, that site has historically, for decades, been a health and behavioral health center, but there are vacancies there, and so the proposed use, which has been in place for several months now, is the Ife Wellness Center, which is operated by Self-Incorporated, and it's providing emergency housing resources that are directed to it primarily by outreach teams So it has served individuals who have been identified both in Center City Outreach as well as in Kensington. Since we spoke, we've been in touch with the registered community organization in that neighborhood, several conversations. That has not been me personally, but the Office of Homeless Services. There's a planned meeting with them, a public meeting where they're inviting the other registered community organizations this coming Monday evening.
This Monday?
This Monday evening. And at that meeting, Self Incorporated will discuss the services there, as well as the owner of the building, Ironstone Realty, will be available because there are many other services on that campus as well. There's a commitment to have a community advisory board, which will also be discussed at that meeting.
Okay, so the current population at the site is what?
For that new use is 40 individuals.
40?
40.
What's prior to the new use? What was the population?
Okay, so prior to the new use, there are people who are using it on an outpatient basis, but I'm going to look to Commissioner Jones in terms of any other residential uses there, which would be funded by his department.
So North Philadelphia Health Systems actually operates a number of treatment programs. So they have residential programs, they have intensive outpatient programs. They actually also provide some medication-assisted treatment. They probably serve, I would say, approximately 3,000 individuals annually.
At that location?
Correct.
3,000. And what percentage are residential and what percentage are outpatients?
So I would say that it's probably about 65% or so residential, about 35% outpatient.
So more than 1,000 are currently living at the site?
So when I say residential, it actually refers to, so like for example, Journey of Hope, so they may be in for a period of time where they are participating in treatment for substance use disorder.
Right.
They actually would then...
yeah, I mean short-term.
Right, it's actually more short-term. It's not, right,
home.
it's not an extended stay. So, let's just say that maybe on average length of stay somewhere, would vary depending upon the individual, maybe somewhere 3 to 6 months or something.
Right, and on average, on a daily basis, how many people are having short-term residential?
So on a daily basis, we would anticipate that there's probably about, in terms of participating in treatment, probably, somewhere 200-300 folks.
All right, so
Who are bed-based or, no, that's...
No, that's not bed-based.
I think we may have to get back to in terms of the number of actual bed-based capacity there in the North Philly Health Systems, unless you know that off the top of your head.
Yeah, we can provide all of the detail.
you'll get back with the actual number?
Yep.
All right. In terms of the newer clientele, now that is with Self. Is that the meeting that we had in my office?
Yes, it is.
And you were talking about 40 individuals?
There are 40 individuals there at the moment. As we detailed when we spoke to you, there's capacity for more, but we're not planning to expand up to the capacity that it has. But we would expand beyond the 40, but that would not be until after we had the meeting with the community and some agreement around that.
All right, so it seems like I can recall a more finite number, and it was much more above 40.
It was.
So
I
if you
think
change
there's physical space that could serve many more people, but as the Office of Homeless Services would say, they try to keep these kinds of facilities smaller, because they're easier to manage.
All right, and was there a location prior to the ultimate selection of 8th and Girard that was looked at by the City of Philadelphia?
We actually looked at something like at least a dozen other potential sites.
And why were those sites not selected?
Variety of reasons. Most often, either that they were not physically suitable, up the condition of the site, sometimes zoning issues.
Is that the only reason?
It's primarily the reason, and frankly, to the extent that we can locate facilities like this on a medical campus, we think it's beneficial because then the residents have access to all of those other facilities. In fact, we're in the process of negotiating a lease for a similar facility, which would be on the Episcopal Hospital campus, that we hope will begin construction in a month or so.
Okay. All right. I want to ask you a quick question about ACUA, net up in the Strawberry Mansion.
Yeah.
You familiar with that? Anybody?
They're one of the...
In Hill School. They're in the Hill School. The net.
Right, I mean, we're familiar, they're a behavioral health provider, and they're also a community umbrella agency under DHS. I'm not sure that either of us
Nobody
would
knows
have
about
the
that?
detail about the CUAs.
So, yeah, if you're asking about the detail of the CUA, as you said, the Community Umbrella Agency, that actually, as the Deputy Managing Director is indicating, so Commissioner Figueroa, that actually falls under her.
I should have asked that question last week.
And I
she
believe
was here.
she's being called back,
All right.
though.
Okay, the reason I'm asking that because
And I'm
there
sorry, if you could, what's the specific question?
so it actually is not, it's related to that operator for a reason. So I recently, maybe 6, 7, 8 months ago, we opened up a council district office in proximity to the site, and we've experienced a number of people coming to the office that have some challenges that we're not prepared to address, mental health, other substance abuse issues. And I'm wondering, because this is literally like 3 blocks away from the net in Hill School, and I'm wondering, people in my office, I came in there to give me a briefing on what's going on. It's like, well, can we have people either from that operator come over to our office, or we can refer people over the net? So I'm wondering, in that close proximity, how there can be some synergy.
We can ask them to
Because
do
we're
that.
not in a position to assist these folks, but they see the council person office, so everybody comes in. Right, Councilwoman? You know about that, right? Everybody comes to the council person's office, yeah.
So we certainly can follow up. So part of what I'm hearing you ask, Council President, is that as individuals may come into your office that may be in need of kind of behavioral health supports, to be able to make those linkages is what I'm understanding.
Right. Yeah, I mean, we want to help folks, but we're just not.
And so we can explore strategies, whether we use work with net, and again, I understand in terms of the close proximity, that's why that's
Yeah, it's
being
like 3
recommended.
blocks away.
Yeah, so we can either do that, or we can also see kind of what other options that are available. But certainly, we can follow up with you on that.
Okay, all right, thank you. I'll come back. Chair recognizes Councilman Don.
Thank you, Mr. President. Good afternoon.
Good afternoon.
I had a question on your budget, a few other questions, but I wanted to start with the budget. In 2018, your budget was $1,264,000 roughly. And this year, the proposed budget's $1,601,000. 26% increase, $336 million. 91% of it, or $304 million, is for purchase of services. Why is there such a dramatic increase? And I realize, by the way, the city this year will pay only $15.9 million of that $1.6 billion. Thank God, that's all we're paying. But why is there such a big increase in the purchase of services, line 200?
Yeah, so just so overall, Councilman Dom, our budget, about 54% of our budget is state dollars, about 45% are federal dollars, and then, as you indicated, about 1% is general fund. That 1% really serves as match dollars for our state and some of our state and federal grants, which is required. So essentially what happens is that Philadelphia receives a $9 return on every dollar invested, right? So I would say that from an investment perspective, it's a significant return. When you look at, I think the other benefit in terms of when you see the increase in our budget, part of what happened is as a result of the Affordable Care Act and Medicaid expansion, we've actually seen the number of Philadelphians who were at one time uninsured, in fact, become insured, and to be specific, be insured through Medicaid. And so we, and those individuals, and where you see, again, the greatest increase is through community behavioral health, which again is our health plan. And I should say that just in terms of kind of efficiency of operation, so the benefit of community behavioral health is that they have among the lowest admin cost probably in the country for a health plan at about, I would say about 9%. They also don't retain any profit, and I would certainly challenge anyone to look at a health plan where it's not their business to attempt to retain profit, but they don't retain profit. Third piece is that, in fact, they, in coordination with the department and obviously the state, they reinvest within 3% of savings back into the city, and then they also have among the most robust benefit packages of any health plan. And so part of why you see that increase is a result of, again, probably over the last 2 years in excess of 100,000 people, Philadelphians to be clear, enrolling in Medicaid, and so you then have the revenue to then pay for the treatment.
So that's tremendous that 100,000 people are now getting covered through Medicaid in Philadelphia?
That's correct.
And before that, how were they handling their medical costs before that?
I'm sorry, I just couldn't hear you.
How were they handling their medical costs before that?
So before that, there were a number of individuals who were uninsured, and this goes back some years. And so through again some of our the state and federal grants, we actually covered the health care for those individuals that were uninsured through those funds.
How many more people are not insured today as we sit here that need insurance?
Well, what I can tell you is that, so for Philadelphia, for a city of, as you know, 1.5 plus million people, currently over 700,000 Philadelphians are enrolled in Medicaid, right? So it speaks to both the incredible resilience of Philadelphians and the high need, again, the deep poverty. So we certainly try to make sure that anyone who is eligible has the ability and access to enroll, and that's, I think, what we can say again at this point is over 700,000.
Are we at a point now where we have to turn away people, or are we able to accommodate everybody?
Yeah, so I think that we actually continue to, as I had mentioned, around the whole reinvestment strategy, so we continue to build out our continuum of care. And so part of what we've really been doing is focusing on expanding kind of our home and community-based kind of treatment options. And so to that extent, we certainly have not had to turn folks away. We actually have continued to build out. And then we've also really been focusing on making sure there's a kind of a high quality piece. And so we've been introducing additional kind of evidence-based practices so that when people make the decision to participate in treatment, that they are getting really quality treatment.
And for you to get the 99% of the monies from the federal and the state basically together, is that something you apply for every year?
So those are grants that that come in each year. It's not necessarily kind of an application process, but certainly part of the, as you well know, with Medicaid, the kind of federal state match, and then the grants are in addition. I would also say that as it pertains to individuals who are uninsured, that we also have a behavioral health special initiative. So for folks particularly who may have more substance use disorder and are uninsured, they actually are receiving services through kind of that unit or division within the department.
Okay, thank you. Another question for you. I believe the deadline's coming up this January 1st, 2020 for all drug and alcohol licensed residential care providers to have medication-assisted treatment available. Just wondering how our progress has been on that program.
Yeah, it's a great question. So part of what what the science has shown is that making sure that people with opioid use disorder have access to medication-assisted treatment is really the gold standard for care. And to be explicit, that includes whether it be methadone, buprenorphine, or Vivitrol. Along with kind of a therapeutic component, right? And so what we've done is we have continued to, given that that's the gold standard and recognizing that there are several pathways to recovery, and by recovery we mean long-term recovery, we want to ensure that medication-assisted treatment is available to everyone.
Okay, thank you. I'll come back on the next round. Thank you. Thank you, Mr. President.
Thank you, Councilman. Chair recognizes Councilwoman Parker.
Thank you, Mr. President, and good afternoon to each of you. Commissioner Jones and Deputy Commissioner Bowen, I'm happy to have you here, but I always like to start with telling you as the leaders of this department how appreciative we are of the people who are actually doing the work on the ground. I host a series of budget briefings and town hall meetings and other community activities throughout the district. My colleagues do the same, and this taboo issue associated with behavioral health and mental health, particularly in the African American community, that was brushed under the rug for so many years. Your members of your team come out to these meetings with information from your department, hotline telephone numbers, identifying locations where people can get service. And so I want to say to everyone, and I can't name them all, but to all of the boots on the ground, don't think we don't see you and know the value of the work that you do. Thank you. No, we do. We appreciate your work. We appreciate
Thank you,
your work.
Councilwoman Parker. It is always a pleasure working with you, and we certainly appreciate that acknowledgement of the work that staff are doing.
Sure. Let me start by saying when I was going through your testimony, Council President Clark, the commissioner made me take a stroll through history because he gave a summary of the creation of CBH. And when CBH was being created, I wasn't a member of this body. I was a staff person for the chair of the Committee on Public Health and Human Services, who was then Marion Tasco. And I remember the struggle that Estelle Richmond Tasco, a young lady by the name of Mary Hurdick, who was then with the Mental Health Association of Southeastern Pennsylvania, and John White Jr., who was the former secretary of the Department of Public Welfare here in the Commonwealth, and now a behavioral health provider here in the city, trying to convince people that maintaining or establishing a behavioral health carve-out would be beneficial to Philadelphia citizens. And I know you weren't here, but I want you to know that a lot of people didn't get it during that time. But fortunately, we moved forward. With that being said, I want you to elaborate for me on some of the benefits for Philadelphians by maintaining a behavioral health carve-out, and just briefly describe what it is so that the listening and viewing public will know.
So, it certainly is important to acknowledge the individuals that you mentioned, Councilwoman Parker, who clearly had a phenomenal vision and thinking through this process in terms of really creating community behavioral health through the carve-out. And so, as the Councilwoman has indicated, the carve-out is really special in that it makes sure that behavioral health services are even more readily accessible, and particularly given the significant stigma associated with seeking and participating in treatment, it certainly would have been, and prior to the creation of community behavioral health, was a significant challenge in terms of people actually accessing treatment. I think as a result, you've also, as is evidence here, you've seen a number of Philadelphian providers that have grown because they're readily available to be able to provide that treatment. And I will tell you that the benefits are, one of the narratives is really around, there's a kind of a push to carve in, obviously. And so and I think that was...
Carve in, help me, I'm
Yeah.
not in your industry, so describe it for me.
So what the carve in means is they want to indicate that behavioral health and physical health should be provided in an integrated way. And so what we would say is that actually that integrated care, kind of whole person care, is actually happening currently with the model. It's currently happening in a model, and so two pieces around that. So not only is it currently happening in a model, and I had mentioned earlier, but there is actually much greater continuity because in the way
Continuity in what, providers?
Continuity of care in terms of so in the current model we actually have one behavioral health managed care organization.
So
right? One, which is community behavioral health. If they were to go with a carve out, we would likely go from one to multiple.
Wow.
And then there would be kind of the disintegrated care that would happen in terms of splinter care when you were trying to then work with the current when you're trying to work among multiple behavioral health managed care organizations and multiple physical health managed care organizations, right?
So just to help walk me through it and just be patient with
Yes.
me because again, this is not my industry. So we have CBH, which is our umbrella, and all of those services are under
Correct.
under CBH versus having multiple providers across the board.
Versus having multiple health plans.
Health plans.
Yes, that's absolutely so. What we know is that there's a higher likelihood if you have a single behavioral health managed care organization that is able to work with individuals, to work with a provider network, and fund that provider network to then provide services, and then also coordinate with the physical health managed care organizations, which currently is happening. And so I'll give you an example. So right now there are federally qualified health centers that that provide both physical health care and based upon the relationship with community behavioral health, they also provide coordinated behavioral health care.
Okay.
And so that's an example of current what's happening on the ground now, where people are able to access health care and get both their behavioral health and their physical health needs met.
So wait. With that being said, now I want to put let's economically. Councilman Don will appreciate this. These are just some general questions, and I want you to just sort of let me know where we stand versus having multiple health plans versus us having one umbrella for us, which is CBH. What is CBH's administrative costs like in the country?
Yes, so what, again a great question, Councilman Parker. So they actually have among the lowest administrative costs in the country. That would be CBH, so which is around 9%. And as I had also indicated, they also don't retain any profit. I would challenge anyone to show another health plan whose business doesn't include retaining profit. And so they don't retain in profit. And what they do with the surplus which is in 3% of savings, is they reinvest that into Philadelphia. It's the most robust benefit package among health plans. And the last thing, I certainly will say again is that, an integrated care in terms of whole person care is currently happening under this model.
So, Mr. President, I know I heard the bell. If you would just give me some leeway on this one, you'll see where I'm going. So I've listened to everything that you've just described to me. CBH has the lowest administrative costs in the country. We don't retain a profit. We invest all of our money back into Philadelphia, and having one behavioral health plan, in essence, allows our constituents to have much better access and a continuity in care. So I want you to correct me if I'm wrong, because with everything that you just stated, Is it true that I've learned that this legislation has been proposed to eliminate the behavioral health carve-out? It's been introduced in Harrisburg. Am I right? I've been gone a long time, so I don't get to do it the way I used to, but a little bird just picked up the phone and called and said, I don't think people understand what's been introduced here in Harrisburg that could impact Philadelphia. Were they accurate or not?
So again, you are on point. So there were legislators from York County that introduced companion bill, House Bill 335 and Senate Bill 268, where they wanted to essentially carve in and do away with a kind of community behavioral health, which we think would be a huge mistake. The other thing is we've actually had an opportunity to brief some of Philadelphia's delegation, and what they've actually said is that they are going to, I'm quoting one individual, it's going to be a hard no against 335 because maintaining the carve-out is just critical for Philadelphia.
So I appreciate that, and I have much confidence in Jason Dawkins and Joanna McClinton, and obviously our Democratic Appropriations Chair in the Senate, along with other members of Philadelphia. But because we're here and we do have 1,001 things to do, we would ask that you all please keep us posted, and we know that the delegation will as well. Mr. President, if you will allow, I just have one other question that I need to ask, and this is relative to having access to, I'm talking about family counselors, therapy counselors, and I'm wondering, what do your ratios look like? And I'll tell you where I'm going with this. I'm thinking about a primarily African-American community, or if I'm in Alny and I have a heavy Hispanic population or Asian population, they are eligible for services, they receive them, but when they go in to get counseling or therapy, how probable is it that the person that they're talking to relative to these services looks like them? So now we're talking about diversity and inclusion, because I'll let you know where I am. I was told that there is an ability to actual individual counseling services in schools, but it doesn't appear that they're meeting students where they are. And so I'm wondering now, when I think about Temple in the Council President's District, I have LaSalle near me, Chestnut Hill. How is CBH addressing that providers are sort of practicing what we would call cultural competency? That's what we talk about with the school district, and not having enough African American teachers when the population is primarily African American. So if I am finally, getting over this concern of finally going to talk to people, which hasn't been traditional for black families and other families of color, and then I finally get the heart to go in and bring my child from a preventive perspective to get the service, and then I'm going down to sit down to talk to someone. It doesn't mean that a person from another race or ethnicity can't support me, but I want to know, what are we doing to ensure that we're recruiting, that the providers understand it's important to have people who look like the people are being served working with them. Yeah. I know that was a mouthful, but it's just a lot. My brain matter contains too much data.
So again, we appreciate the question, and I think as it pertains to both cultural and linguistic sensitivity, right? I think that we are continuing to see the network expand in that way, that we actually have seen, I think, over from 2011 to 2018, we've probably seen about, I think it's about a 45% growth in our funding allocated to minority or women providers. And we've also seen, just in terms of the number of providers, about a 3% growth, again, over that same period of time. And so, we are very cognizant of the fact that we want to have our provider pool represent the great diversity of Philadelphia, and so I think we are continuing to both develop the pool in that way, or I should say develop the number of providers in that way, being very conscientious about that. We include that type of, because it's a priority, we include those requests and that language in our procurements. It's also in our contracts, so it's not that we're doing it as a one-off. What we can also say too is that in terms of the workforce, if I were to point to our handy dandy, if you will, flyer that talks about our minority, women, and disabled owned business enterprise participation, we'll see that the workforce actually is about 68% minority, and that it's actually about 97 almost % women. And so I think what most people will find once they get past the stigma, because sometimes I think there's a narrative out there that if you go in, you don't have Spanish speaking, or you don't have, whatever you don't have, African American therapists. And I can attest that there are folks actually who are here today that run those clinics and run those operations, who will say, listen, it's African American owned, it's African American operated, and they're very conscientious about making sure that as they bring therapists in, again, they represent the diversity of Philadelphia.
Thank you for your leeway, and I'll put a pin in that and come back during the next round for follow-up.
Thank you, Councilwoman. Chair recognizes Councilman Dom.
Thank you, Mr. President. And I want to try to make sure I understand something.
Okay.
Your budget's $1.6 billion.
Correct.
Cost the general fund roughly 1%, $16 million.
Correct.
Public health's budget is $645 million, and we contribute 9.5%, or about $59 million, from the general fund. So clearly, whatever can go through DBH is much better than going through public health from a reimbursement standpoint. Have we looked at these two budgets, and it looks to me like the allocation, if you had a choice of where expenses are going to go, they should go through DBH versus public health. So we maximize that advantage that we have, because DBH, we only contribute 1%, and through public health, we contribute 9.5% of the general fund.
Yeah, so I'll start responding, and then I can see that Deputy Managing Director Eva Glassing is coming up. So our the way our funding flows is that there is certainly, it's very prescriptive around what would come in through kind of the Department of Behavioral Health and how those funds can be allocated. Different than I think sometimes the guidelines and the funding kind of requirements and regulations that would predict or dictate, I should say, how funding flows through the health department.
I'm not doubting it. I just want to make sure that we're fully aware that if there's an option or a choice, it's better to get reimbursed 99% than 90.5%.
Good afternoon. I think I want to add to that and clarify. The health department has ambulatory health care services, or direct provision of health services for which they are reimbursed at the same rate as behavioral health, but it's a small part of their overall function, so that they have a lower match rate because they're also providing a variety of other services, and that could include restaurant inspections, air management services, vector control, which we've talked about, and many other services. So those have to be funded through other sources, and they don't have the same formula reimbursement rate that the Department of Behavioral Health has, which is primarily focused on providing treatment. The health department just has a broader array of resources, but in both cases, the matching is under a formula, federal and state formulas, and would be the same for each if you were looking apples to apples at the services provided.
Okay, I understand. Thank you. I want to follow up. I think Council President had an opening question about the increase in the health choices. And do you have any idea how many people are not enrolled in CBH that you believe are eligible?
So as I had indicated, I think, so we know that over 700,000 are enrolled. And part of what we continue to do is through the provider network, they are certainly constantly reaching out to Philadelphians and helping with making sure that they are enrolled in all the services, or at least have access to all the services that they are entitled to. We don't necessarily have any information that indicates that that there are individuals who should be enrolled that aren't enrolled. Part of what you tend to do is you look across the country, and I would say that that they're typically, when you think about utilization, you tend to be around kind of 20%, of which we are obviously in excess of 20%, and so would say that, again, I think we certainly are doing well with getting Philadelphians enrolled in Medicaid.
But we don't have any idea of what the potential is that we could enroll.
So I think that the way we could potentially kind of back into that number is just to look across the board to see kind of, just in terms of the various means testing and, so who's able to be enrolled based upon salary and those needs, and see if there are individuals that that have not taken advantage of the opportunity. We can explore that. At this point, we don't have any data that speaks to that.
Okay, thank you. Last question I have is the performance measures show that you served nearly 115,000 unduplicated persons in fiscal year 18. And the goal for fiscal year 20 is 95,000 people served. Just curious why the goal for 20 is lower than what we accomplished in 18.
Where is that? Where are you looking at?
In your performance measures, you show that you served nearly 115,000 unduplicated persons in fiscal year 18.
Mm-hmm.
And the goal for 20, fiscal year 20, says 95,000 people will be served. It's 20,000 lower than the goal of that we accomplished in 18.
So I think that that's in part attributed to, at one point in time, we actually had anticipated that there would be, and this actually I'm going to dovetail back to your previous question, that we had anticipated that there would be a larger number of people who were uninsured that were served, and so as we've seen more people become served, then that obviously
that's going down.
Right, exactly.
Okay.
And Councilman Dome, I did want to circle back. So, just in terms of the potential number of individuals who aren't currently enrolled in Medicaid, so when we think about that, would then be kind of some of the uninsured individuals we're serving now. That number is at about 35,000.
Oh,
right?
Okay.
Now, there would be various reasons for some of those individuals. Some of it could be around that it actually could be documentation status. There are various reasons why they're uninsured. So I wouldn't necessarily say that it's a one-for-one in terms of that all 35,000 could be, but certainly probably that would be the range.
Okay, thank you very much.
Sure.
Thank you for your testimony. Thank you, Mr. Chairman.
Thank you, Councilman. Councilwoman Parker?
Thank you, Mr. Chairman. Commissioner, I want to go back to the issue that we ended on, and I compared it, the cultural competency of therapists and counselors, to that of teachers. And one of the issues that Dr. Height and members of his executive team have raised consistently about the decline and or low numbers of minority teachers in the school district of Philadelphia, has been that either they don't choose to come to the district, they'll choose other regions that pay more, and or they're just so few who are majoring in education and choosing it as a field of a study. With that being said, what is the the academic requirement or teaching assessment and or a tool. So, I'm teaching is what I know. I'm a certified secondary English teacher. So when I graduated from Lincoln, I was required to take the NTE and pass it, but I also had to take a test called Praxis, and that was to affirm my proficiency and ability to have mastered English and teach it to high school students. What is that for therapists? Is there a special kind of certification that family therapists have to have in order to actually provide the service? And if so, has there been any challenges in us seeing African Americans in particular pass whatever the teaching assessment is? Is there any challenge there?
Yeah. So again, I think that so there is variation depending upon the discipline, and so so we have, for example, social workers will have psychologists, we will have psychiatrists, we'll have other master's prepared clinicians who would provide, relative to your question, would provide kind of the bulk of the treatment.
These are the master's level clinicians, and so they would be like therapists who are not psychologists.
Correct.
Okay.
So yeah, exactly.
And that's the group. That's the group that I'm concerned about, because I was at a meeting probably about 6 months ago, and I had someone to mention to me some sort of testing that has to occur in order for you to obtain a certification. And I remembered the challenge in minority students sort of passing that NTE and Praxis. I was fortunate. We weren't there. We were doing well, but there were so many others that did not. And so I asked the question, Doc, not as a criticism in any way, but to ask if you could go back, you and your team go back and evaluate whether or not it is possible for your department to work with any of the institutions of higher learning in our region, take an assessment of any specific courses and or programs. You know, it's almost like going through the SAT prep program, and as we just learned from this interesting debacle relative to access and testing, we know that all people don't pass because they are doing well. And so we always want to level the playing field. And I'm wondering, for that constituency in particular, I would like to know if I have anyone in my district who's interested in doing it. I would love to be able to say, hey, I know you're an undergrad, or you know, you're preparing for the test now. You know, we're the city of meds, eds, and beds, and I know you can go to Drexel, you can go to LaSalle, you can go here. They have a cohort that's 6 months that, you know, you can go through that can help to get you prepared. I'm just telling you that as an elected official, I don't know that. You know, and have that information to share with them. So I would love to work with your department on that and help to find a way to disseminate that information to as many people as possible, because I think that will help us ensure that the pool of those, particularly those master's level clinicians that you referenced. And I'm glad you sort of defined it that way, because you described exactly what I was referencing, particularly those who are preparing for the certification test. I want to make sure that they have access to as many opportunities that can help them prepare as possible, because not everybody can afford Kaplan.
Absolutely. We are absolutely committed to working with your office. I think that, you know, in addition to some of the current strategies where our department and then through the provider network offer internships so that they you can help to develop both the skill sets and then get the additional information that would make whatever those barriers are less challenging. And then I think the other thing is we also are continue to look at how we provide and support continuing education, again, as another strategy that we utilize to then help, again, in any of those individuals overcome some of those barriers. So we will continue those strategies and welcome opportunity to work with you, Councilman Parker.
That leads into my next question, and I think you also just helped me touch it just now. The reason why this part of this is so important to me is because many of the employees of CVH, unlike some others who benefit from doing business with the city, they live here in Philadelphia. And so these are homeowners, and we want to ensure that they have access to an opportunity to earn a wage that will allow them to be homeowners and to successfully contribute to our economy. Nothing more frustrating than you know that you're doing the work of the master's level clinician who has been fortunate enough to pass the test and achieve the certification, and you haven't been able to pass the test and achieve the certification, but you know you can work circles around that person who did much better, you know, academically on the test. And so that's why I'm asking the questions about the barriers to sort of passage into getting there. With that in mind, tell me about how are we addressing the city's new minimum wage mandate?
Yep. So if I can just also share just one initiative that's underway within DBHIDS, also that so you have the master's level clinicians that you just referred to, Councilwoman Parker, but we also have what we're referring to as a family legacy organization, right? And so within the family legacy organization, part of what we are planning to do is these are now family members whose children have gone through the kind of behavioral health system. And they certainly have a great expertise in terms of being able to navigate the system, understanding how to communicate with other parents who may be going through the system. But some may not have those kind of traditional educational credentials in order to be able to make, if you will, kind of a living, right? And so part of what we're doing is we're looking at how to create a career pathway for some of those family members, and we think, and obviously the collateral benefit will be that their families would benefit. And so we're talking about having those individuals be employed through, so we would push out funding that would go to a nonprofit again, and it would be this family legacy organization, and they would have a career pathways where they did things like they may be resource coordinators, they may be family support partners, they may be family navigators, and they're able to, earn what we would plan for to be, higher than, or at least equivalent to a living wage. And I'm going to pick, dovetail into your second question, so that would then lift, candidly, some families who may not have had access to both a career pathway and a way to sustain their families. That would actually go to help lift them, if you will, kind of beyond, kind of out of poverty, right? And so that's a strategy that we're moving forward. And then as it pertains to how we are looking to address kind of the living wage issue. So part of, throughout the department and specifically also within community behavioral health, we are looking at how our rate structure. And so there's a plan to do kind of a rebasing of those rates that then would take into account the higher cost of salaries for the, if you will, for the therapists and other kind of professionals within the provider network as a way to offset that. So that's part of the kind of broader strategy that we're looking at in terms of how we would then address kind of living wage going forward.
Okay, we want to make sure that you keep us posted on that. I mean, we were proud when we passed the effort here in council, but we also want to make sure that you're paying for it, right? And that when you're doing your work, you're assessing it, you know that people are earning more, and that sort of when you're paying for the services that you take that into account, so I appreciate it. Thank you, Mr. Chairman, for your leeway. And Commission, listen, if you all hadn't been responsive every time we called, if we thought you and your team were doing a crappy job, I want you to know I would call you out publicly right here. I wouldn't have a problem doing it. But when your team is responsive, and I don't care if it's tough, if I need to see you, Nicole, anybody I need to see in your office, they answer the questions, and I don't ask easy questions. I want to thank you for being straightforward, even when I don't like the answer. So thank you very much.
Thank you, Councilman Clark.
Thank you, Councilwoman. No further questions. Thank you all. Thank you for your time today. Thank you for all you do. This committee will stand in recess until Wednesday, April 24th, 2019 at 10 a.m., at which time we will reconvene here in room 400 City Hall. Thank you.